Committee will come to order. First off, I want to welcome all of our witnesses to the hearing here today. I thank you for being here. And before we get started, I'd like to take a moment to recognize our Gold Star Family Remembrance Week, which honors the families who have lost loved ones in service to our nation. Their sacrifices will never be forgotten, and we extend our deepest gratitude to them. I also want to take a moment to welcome back to the committee, I hope he's not having flashbacks, former VA Secretary Bob McDonald is in the room. Well, today we're going to discuss the critical issues facing veterans caregivers. Veterans caregivers play an unseen role in supporting their loved ones, the men and women who serve our country. Caregivers include veterans, spouses, children, parents, making countless sacrifices to care for their loved ones. Many of these caregivers face emotional, financial, and physical hardships because of their care that they have to deliver for their veterans. As a veteran who comes from a military family, I understand these challenges firsthand. My uncle returned home from Vietnam with visible and invisible wounds of war and went on to live a very successful life, but that required some care and attention from the extended family. Now, just yesterday, the RAND Corporation published a report on challenges and hardships millions of military families live with every day. This report sheds light on the evolving demographics of caregivers, with more aging parents and young children taking on caregiver roles. One of the major concerns in the report, which we have also heard from advocates and stakeholders, is the lack of access to mental health resources. Caregivers are often isolated and experience high levels of stress and burnout. But many are unaware or unable to access VA resources such as caregiver-specific mental health support groups. This is especially true in rural parts of this country, like my district. Now, provisions of the Senator Elizabeth Dole Act taken from Ms. Kiggins' COPE Act will require VA to award grants to improve the mental health support for caregivers. This is an important step towards addressing the mental health stigma and giving caregivers the support they need. Caregivers' families face economic pressure as many are forced to reduce work hours or leave employment entirely. While some financial support is available through the VA stipends, it often falls short. Beyond these challenges, we must address the Biden-Harris administration's failure to release new regulations from the program of comprehensive assisted for family caregivers. The administration has dragged its feet on these changes and leaving thousands of caregivers in limbo. Caregivers support the men and women who have served, and it is about time that the White House and VA put some action behind their words. We are even hearing now from caregivers that VA has slowed down services and new programs since disclosing their budget shortfall. It has been a battle getting clear information from VA about the VHA budget shortfall. But based on what we know, none of the caregivers' budget accounts seem to be included. So it is troubling and confusing why this is happening. Now, I understand that the administration and the VA leaders are urging Congress to immediately approve the VHA $12 billion budget shortfall without us asking questions. Well, today's hearing will help us hold VA accountable and determine the actions needed to ensure caregivers receive full support they deserve. Now, finally, as I previously mentioned, the Dole Act is critical legislation to improve services for caregivers. The Dole Act expands access to home and community-based services for veterans and would expand mental health support for caregivers. I can't imagine anyone that would vote against this. And I hope to bring the bill to the floor very soon. It's time to put the politics aside and support the needed legislation. Now, I am eager to hear today from VA about how they plan to address the challenges of the veterans caregivers and the community that they serve. We also look forward to learning from our expert witnesses, but most importantly, we will hear directly from Vanessa Chism, an Elizabeth Dole caregiver fellow who cares for her husband every day. Her testimony will provide a powerful perspective on the day-to-day life as a veteran caregiver. I'd also like to welcome the Elizabeth Dole Caregivers Fellows who are advocating for caregivers on Capitol Hill today. I especially would like to welcome Teresa Comer from the great state of Illinois. Thank you for being here. Thank you for your dedication and sacrifice. We see you, all of you caregivers, and as long as I'm in charge of this committee, I will make sure that your voice is heard. With that, I now recognize Ranking Member Takano for his opening statement.
All right. Well, thank you, Mr. Chairman. Caregivers are an indispensable component of the complex network of healthcare delivery for our most vulnerable veterans. As we can all see from RAND's new report, caregivers are not only partners, children, friends, neighbors, and loved ones, but also a critical lifeline for those who are living with the visible and invisible wounds of war. They take time out of their own lives and make sacrifices every day to ensure that the veterans in their lives have the best possible health care and highest possible quality of life. They wear many hats. They are advocates for veterans' health care needs, carers who help veterans with daily tasks, and often the most trusted members of their veterans' support systems. Together with their veterans, they often must navigate a complex system of services and supports, overcome hurdles after a bureaucratic hurdle, often at the expense of their own mental health and financial well-being. I'm glad that we can gather here today to acknowledge the tireless and priceless sacrifices made by veteran caregivers and to ensure that we are doing all we can to provide them with the support and resources they deserve. So I look forward to hearing from RAND and the Elizabeth Dole Foundation about their new report. I'm interested in hearing more about what they found about military and veteran caregiving, the military and veteran caregiving population, and how its needs have changed over the past 10 years. I'm also glad we will have the opportunity to hear firsthand from Ms. Vanessa Chism, who has been a full-time caregiver for her Army veteran, Cody, for the last 15 years. The perseverance and resilience she, along with her 3 children, have shown in caring for Cody are nothing short of remarkable. I look forward to hearing from other witnesses on panel 2 about how they are working to support caregivers and their recommendations to continue to support this vital population. Much progress has been made, but there is so much more to be done. Finally, I look forward to hearing more from VA about how it plans to strengthen and expand services and supports for caregivers. I hope we'll hear more today about when VA finally plans to issue its Notice of Proposed Rulemaking for the Caregiver Support Program. Legacy participants of the Program of Comprehensive Assistance for Family Caregivers have been waiting in limbo for years to find out whether they will be able to stay in the program and continue receiving the stipends and services they rely on. Now, before I close, I want to acknowledge the advocacy of several witnesses on our panel for H.R. 542, the Elizabeth Dole Home Care Act, which was authored by my colleague, Representative Julia Brownlee. Now, this legislation would be transformative for elderly and disabled veterans and their caregivers. It would enable veterans to remain at home, safely age in place, and avoid or delay admission to nursing homes and other costly institutional settings of care. It will also help better connect veteran caregivers to respite care and other supportive services that can help them care for veterans at home. In addition, this legislation will help improve VA's coordination with other federal long-term care programs that promote aging at home. Now, for many veteran service organizations, the Elizabeth Dole Home Care Act has been a top legislative priority since its original introduction in 2022. I, too, want to see this legislation enacted as soon as possible. Ensuring that VA can serve all veterans and caregivers of every generation is critical. VA must have the resources it needs to continue to build capacity and modernize infrastructure so that we can have the very best services for those who have earned them. What this means is doing the hard work of putting VA on the right track with regard to the balance of health care dollars in both direct VA care and community care. Now, this has become even more important with the thousands of veterans coming into VA for the very first time with the successful implementation of the PACT Act. That means every piece of legislation we move forward must recognize and support the need for that balance between direct care and community care. H.R. 8371, the package that many of you have advocated for, does not do that yet. It is 90% of the way there, but the remaining parts need to be reconsidered and amended. Now, I appreciate your advocacy, but I have been clear about what changes I think are absolutely necessary to ensure the solvency of VA. And without those changes, I simply cannot support it at this time. However, as I've said repeatedly, I stand ready to work together on an outcome that meets our goal of serving veterans and those that care for them. If everyone is willing to work in a bipartisan way, as has been the practice of this committee, I do think we can get that accomplished. So thank you, Mr. Chairman, and I yield back.
Thank you, Ranking Member Takano. We will now turn to our witnesses in the first panel. Testifying before us at the first panel is Dr. Colleen Richardson, the Executive Director of the Department of Veterans Affairs Caregiver Support Program. She's accompanied by Ms. Laura Duke, the Chief Financial Officer of VHA. Dr. Richardson, you are recognized for 5 minutes for your opening statement.
Good morning, Chairman Boss, Ranking Member Takano, and members of the committee. I appreciate the opportunity to discuss VA's Caregiver Support Program. I'm accompanied today by Ms. Laura Duke, VHA's Chief Financial Officer. As a Navy veteran, former caregiver, and the first clinical psychologist with Marine Corps' Wounded Warrior Battalion at Camp Pendleton, I understand firsthand the important role caregivers play in the lives of our veterans. I am honored to serve as the leader of VA's Caregiver Support Program. This isn't just a job for me, it's personal. My goal is always to lead with honor, courage, and commitment, the same values I learned while serving with the Marines. I value delivering supports, education, resources, and services to our caregivers through our 2 national programs, the Program of Comprehensive Assistance for Family Caregivers and the Program of General Caregiver Support Services, PGCSS. Each year I designate a theme which drives the vision and the operational focus for the year. Annual themes are identified using feedback from caregivers, veterans, staff, and strategic partners such as veteran service organizations, members of Congress, and others. In FY24, the theme, The Year of the Caregiver, the whole caregiver, was focused on enhancing the delivery of clinical support services to caregivers and implementing other programmatic and process improvements. I'm excited to share the progress we have made towards some of those initiatives. First, we recognize and know the importance of providing respite services to our caregivers. CSP trained respite champions in each VISN to serve as subject matter experts in the benefits of respite, respite services, and respite funding. As a result, we have seen tremendous growth in the utilization of respite care, which has increased 278% since FY22. We are thrilled to see more caregivers taking advantage of this well-deserved benefit. Additionally, CSP implemented a virtual psychotherapy program for caregivers, or VPPC. Through the VPPC, VA is better able to address and provide the mental health counseling family caregivers request and deserve. CSP has activated hubs in all 18 VISNs. The VPPC is on track to complete over 14 psychotherapy appointments this fiscal year. Just as when we fly, we all hear the safety instructions that if air masks deploy from the ceiling, put on your own masks before helping others. This applies to our caregivers. We need to support them to take care of themselves so that they can take care of their veterans. This is what respite and mental health care are all about. And finally, we heard overwhelmingly from caregivers of their desire to receive CPR training, so we made it available. Excuse me. CSP partnered with VA's Center for Development and Civic Engagement and SimLearn to design a process to train caregivers in CPR. CSP has provided educational support such as CPR and basic life support certification to caregivers nationally. Today, CPR training for caregivers has been implemented at 70 sites and continues to grow. These trainings have been highly requested by caregivers and empower them with the life-saving skills needed to support their veteran in the time of an emergency. I could talk about many other innovative ways we are supporting caregivers through CSP, but these milestones do not overshadow VA's recognition and my recognition that there is more work to be done in support of our caregivers, and specifically more work to be done to improve PCAFC. While I'm proud of all that we've accomplished and the hard work and dedication of our employees on the caregiver support teams that exist at every VA medical facility, I also recognize that there is more that we can do. We have heard through various engagements and listening sessions that some of our evaluation criteria for PCAFC is too restrictive. We've taken a close look at all aspects of PCAFC to identify areas where we need to get better. And as announced in the spring unified agenda, VA intends to issue a notice of proposed rulemaking to propose amendments to PCAFC eligibility criteria and definitions, and to consider other changes to the evaluation processes. I am pleased to share that a notice of proposed rulemaking was submitted to the Office of Management and Budget this year. I am limited in what I can share, as the rule remains under review while we continue the deliberative process with OMB regarding proposed changes. However, once the notice of proposed rule is published, VA will announce this information widely and encourage submission of public comments and feedback to identify whether additional changes may be needed. This marks a significant step towards VA's efforts to further improve PCAFC and deliver a program which meets the needs of eligible veterans of all eras and their family caregivers. I appreciate the continued support of this committee, VSOs, some of whom you'll be hearing from on the next panel, and the vast caregiver community. Your support and advocacy are essential to supporting our nation's veterans, as well as those who care for them. On behalf of the Department of Veterans Affairs and the Caregiver Support Program, we thank you for the opportunity to be here this morning and appreciate the continued collaboration.
Thank you, Dr. Richardson and Semper Fi. We are now going to go to questions, and I will recognize myself for 5 minutes as soon as I mark my script where I'm at. Dr. Richardson, why is VA delayed publishing the pending caregivers PCAFC proposal rule for 2 years?
Thank you for the question. So CSP and VA has taken a step back these last 2 years through community engagements, meeting with VSOs, external partners. I thought it was really important that we gather the information that they felt was critical and what we were missing today to be successful in implementation of this program. So we've taken that time these last 2 years to really look at the criteria, where it stands today, and what changes need to be made. And as I mentioned, sir, we have submitted that notice of proposed rulemaking to OMB, and we continue that deliberative process and discussions with them today.
You know, 2 years is a long time. I know government moves slowly, but our witnesses on the second panel have concerns about the holdup. And so what would be your answer to them, other than the answer that you just gave, or would it be the same?
I would say, you know, when we opened this program up the first time on October 1 of 2020, we didn't get it quite right, and I don't want that to happen again. And so now that I'm leading the Caregiver Support Program, I think it is my duty and obligation to these fellow caregivers to make sure that we get it right this second time around. And I want to be careful in that process.
Well, caregivers in Illinois are having issues accessing respite care. And how can VA improve access to these programs designed to give caregivers a break?
Yes, sir. So we noticed that as well, sir. We had a very low respite utilization when I first came on board. Roughly around 7% of our budget was going towards respite at that time. So what we heard through listening sessions, I've probably done over hundreds of listening sessions, both in person and virtually with caregivers across the country. Took an opportunity to see what it was that they needed to be successful in this caregiving journey, and also to identify what they weren't identifying for themselves. And as we all know, caregivers hardly ever take the time they need for themselves in their caregiving journey. So we heard respite was one of those things. And so what we did was and now they are experts, and they have gone, I believe in the train the trainer model. Mm-hmm. So they have gone now into the medical facilities and trained the local staff. We have seen an exponential increase in respite. It's still not enough. I still think caregivers need to take more advantage of the respite that is available to them in both programs. So PGCSS and PCAFC, by statute, thanks to Congress, no less than 30 days of respite is offered to our caregivers across the country.
Wonderful. Ms. Duke, why is the VHA budget shortfall requesting via the TIF account instead of normal accounts?
To the extent that Congress provided adequate funding through the creation of the TEF to ensure that we would be able to continue services for those veterans who have toxic exposure, I can commit that if Congress provides the shortfall as requested in TEF, we will be able to execute that funding against the care needs of this population in 2025.
Well, let me tell you what we feel here, and I mean, the concern I have is that the administration of OMB and VA are trying to avoid the Fiscal Responsibility Act spending caps and create a funding gimmick. And so that's my concern, because the way the TIF is written, it allows you to spend freely, and we don't have to always get the reports back from VA. We'd really like to get on how and when it's being spent. So that's our concern, and I think you need to know that. Dr. Richardson, no spouse caregiver often feeling ignored by the VA, non-spouse caregivers often feel ignored by the VA. What supports services does VA offer to parents and or children and or non-spouses that are the caregiver?
Sure. So for the Program of Comprehensive Assistance or the Program of General Caregiver Support, we can offer supports and services if they're enrolled in either one. So for PGCSS, our Program of General Caregiver Support Services, there is no application for that program. So as long as a veteran is enrolled in VHA healthcare and identifies somebody that takes care of them, whether it's helping them with day-to-day tasks such as dressing or bathing, or helping them with supervision or protection or instruction, we can offer supports and services to that particular caregiver. Doesn't matter if they're a spouse or non-spouse. And then we partner with other organizations to help children and families across the country.
How are you getting that message out?
So upon initial application, so we have a couple things that we do right now. So we realize that there are a lot of people out there who still do not know about the Caregiver Support Program. So I hired an outreach coordinator within the VA Central Office and a communications director. We've attended, I think, over 70 national events in the last couple years, just trying to get our word out there that we have this program. It is available to all caregivers and veterans who are enrolled in VHA healthcare.
All right, thank you. My time has expired, and I now recognize the ranking member, Representative Taco.
Thank you, Mr. Chairman. My first question is to Dr. Richardson. In your testimony, you state that the number of caregivers using respite care has increased by 278% since fiscal year 2022, which is just 2 years ago. What percentage of participants in the family caregiver program have actually been served?
Thank you for that question. So you're talking about the Program of Comprehensive Assistance, sir?
Yes,
For
ma'am.
family caregivers. I do not have that number right in front of me, sir, but I can get that for you if you'd like.
I would appreciate that. How much of this respite care is VA providing in-house versus referring to private sector providers where veterans and their caregivers are in competition with non-veterans who may have more resources to pay out of pocket?
Yes, sir. So a majority of the care is provided in the community. So respite care is something that we contract with out in the community to provide services for our veterans in their home. We realize that this is not always the best option for our veterans, so today we are piloting something called VDC Respite, Veteran Directed Care Respite. It is being piloted in 11 sites across the country, some of them being rural sites as well. What we've realized and what we've heard through listening sessions is that our veterans and caregivers would prefer somebody that they know to come into their home to care for their veteran, and we agree. So we have partnered with VDC, or as long as a veteran is duly enrolled in VDC and CSP, PCAFC, we will pilot this program to see how well it works with our veterans across the country, and then I hope to expand that as we move forward into the future.
All right, well, thank you. I was concerned to read in Ms. Chism's testimony that in the past 12 years she has participated, in the past 12 years that she has participated in VA's Family Caregiver Program, she has never been able to access respite care, nor has she been able to enroll in the Veteran-Directed Care Program, which would provide funds to hire someone to help. What are some ways that you are working to improve caregivers' aspect? You've already mentioned some, but to improve the caregivers' access to respite care.
Sure. So we train those 18 champions across the country to make sure that our staff understood, because we know respite is different at every VA across the country. Community resources are different across the country depending on where you live and how you get those services. So that is something that we've really focused on this last year, and there's always work to be done. We're fluid and flexible, and I want to continue to move in that direction.
Dr. Richardson, well, thank you for that. One thing that struck me from reading RAND's new report is that more and more caregivers are reporting a need for mental health services, but they often cite a lack of time to travel to mental health appointments as the reason why they don't seek it out. I'm glad to hear that VA has implemented a virtual psychotherapy program to help address this, and it seems like even in the community, virtual psychotherapy programs are kind of becoming more of the norm. And that this program has nearly had 14,000 visits. Does that number reflect the total number of requests for care that have been received, or is there still unmet demand for the services beyond the nearly 14,000 visits that you have provided?
Thank you, sir, for that question. I think there's always a demand for mental health care, and sometimes people don't recognize that they have that demand for mental health care. So I think some of the things that we do that traditional psychotherapy, as we mentioned, the virtual psychotherapy hubs that we offer for that we offer for our caregivers enrolled in PCAFC. The other thing that we do are in-person services, and you're right. 51% of the caregivers that we surveyed asked for virtual psychotherapy. It's often hard for them to get the veteran loaded into the vehicle, bring them to the local medical facility, and take advantage of those in-person appointments. So that's why we hired our own staff, 54 staff across the country, to specifically care for our caregivers. In addition to that, we're training this is the first of its kind. I know of no other program that exists that focuses on the specific needs of caregivers. And as a clinical psychologist, measurement-based care and evidence-based treatment for the treatment of our caregivers is really important to me. And so that's something that we focused on this year as well. We're training our providers in evidence-based care for our caregivers, and then we're also measuring that to see how it's impacting their quality of life.
Well, Dr. Richardson, even though a veteran and caregiver may be found ineligible for the program of comprehensive assistance for family caregivers, they're quite likely to be eligible for a variety of other institutional programs that VA administers. However, we often hear from caregivers and advocates that the caregiver support program is not always facilitating warm handoffs to other services. And to what extent is VA working to improve coordination among its programs to ensure that warm handoffs are made? And I may need to just take this back because I don't want to, we have a lot of members here and I don't want to intrude on other members' time. So maybe you can get that back to us, or maybe another member will give them their time. But I yield back, Mr. Chairman.
Thank you, Ranking Member. Representative Rosendale, you're recognized for 5 minutes.
Thank you very much, Mr. Chair, for holding this hearing today. The people who care about and care for our veterans, better known as caregivers, play a vital role in supporting the health of our veteran population. Unfortunately, these caregivers often don't get the necessary attention and support they deserve, and I'm grateful that this committee is conducting this hearing. Caregivers, typically family members or close friends, help veterans with necessary activities that are essential to living, including eating, dressing, and bathing. Caregivers are the biggest advocates for veterans, helping them get to and from doctor's appointments, ensuring their bills are paid, and interests are being looked out for. Being a caregiver entails great sacrifice, and we have seen touching stories of individuals giving up their prior careers to care full-time for a loved one. A recent study from the Associated Press Newark Center for Public Affairs Research found 88% of Americans would prefer to receive any ongoing living assistance they need as they age at home with loved ones, which is the same information that you're sharing with us. Just 12% want to receive care in a senior community or nursing home. Caregivers allow veterans to live at home, surrounded by their loved ones. I want to ensure that Congress continues to give needed support to caregivers so they can continue to care for our nation's heroes. Dr. Richardson, I've heard firsthand reports from many individuals who want to be caregivers, but they feel they lack the necessary qualifications. The RAND report highlighted this fact. What steps are the VA taking to ensure that caregivers have the proper training to care for veterans?
Yes, sir. Thank you for that question. So as I mentioned, we have done listening sessions, but in addition to listening sessions, we have done V-Signals surveys. We have a 26% response rate, which is extremely high. And in this, we look at those opportunities to see what it is that caregivers need to be successful. We may think we know what they need, but that's not always 100% accurate. So it's important for me to hear from the consumer of what we do. Some of those things that we've heard just in the last 2 years have been mental health. We've gotten that. CPR, we've done that. Respite, we've done that. We've also heard they need additional assistance with just different diagnoses, different ways to be successful in, for example, transferring their veteran from the bed to the chair, or from the commode back to the chair, in and out of the bathtub. We've also heard, as you know, veterans of different service eras have very different and unique caregiving needs. They're not the same amongst the service eras. And so what we've also heard is that our caregivers need not only CPR, but CPR, what we're calling CPR plus. So we've partnered this year. So this coming year, we will have diabetic emergency. We will have first aid, falls, head injuries, SCI. We're adding more and more resources based on what we hear, not on based what we think they need.
Very good, very good. Thank you so much. Ms. Duke, I'm going to go into the financial end of these things. Obviously, we want to make sure that the proper funding is provided and that it's being fully utilized. As you know, $3.4 billion of your $12 billion shortfall is for medication. You've explained this as a result of new high-cost drugs that don't have generic versions. The main drugs are injectable diabetes and weight loss drugs and resmetirom for liver disease. How much in fiscal 24 did the VHA spend on weight loss and injectable diabetes drugs?
I don't have that number with me, but we will get it for you. But I do think that the reason for including it in the shortfall analysis was the concern that this would be a growing need for our veterans based on the trends that we've seen outside.
It is, and this is exactly the line of questioning I want to get to, because as in my previous job as the Commissioner of Securities and Insurance for the state of Montana, I did an incredible amount of research on healthcare and the cost of pharmaceutical drugs, and know that it is a major driving cost for healthcare. How much do you plan on spending in 25 on these medications, fiscal 25?
I'd have to get that specifically broken out by medicine.
Okay, please get that information for me. A recent study found that those taking any form of semaglutide lost an average of 39% of muscle mass. Another study found that these weight loss drugs come with a heightened risk of gastrointestinal problems, specifically a 3.67 time higher risk of stomach paralysis. We also know that the need for these drugs to be effective for weight loss has to be taken for a lifetime. Why does the VA think it's a good use of taxpayer money to spend thousands of dollars per month for veteran on drugs that have so many side effects, require a lifetime of taking for any benefit, are way more expensive than in Europe, and fail to address the root cause of the veteran's metabolic dysfunction?
I will take that back to our pharmacists to make the ultimate determination regarding what the standard of care is. I would just say
This
that
has got to be a coordination, not just pharmacists, but the physicians within the VA have to start addressing the root cause of the problem instead of just treating the symptoms, okay? That's what we need to get at. And the food, the diet, the exercise, we have to begin to incentivize that to get our arms around obesity instead of just giving everybody a pill. Thank you, Mr. Chair. I yield back.
Thank you. Representative Brownlee.
Thank you, Mr. Chairman, and thank the panelists for being here. Dr. Richardson, my first question is to you. I think we're all very much aware that VA suspended in 2022, suspended its annual reassessment of eligibility for the legacy cohort within the family caregiver program. And this pause was to better understand the impacts of that reassessment criteria. We all know, I think probably all of us here agree that ineligibility for this program would certainly upend the caregiver's ability to do their job, and would certainly upend the veterans who need these services as well. So my bill, the Elizabeth Dole Home Care Act, I think would provide a really more than adequate transition for both these folks in the legacy cohort, as well as new caregivers and new veterans who are going to need these services. And I know that you have made it very clear that you're not going to provide us with the criteria that you're evaluating now, but do you believe that the Elizabeth Dole Care Act would provide that transition successfully?
Thank you, ma'am, for that question. I believe VA has offered TA and views on that, and I apologize, ma'am, I don't have that in front of me to further comment from VHA's standpoint on that.
Are you aware of the bill?
Yes, ma'am, I am.
But you can't make a personal assessment or comment?
Ma'am, I always appreciate the opportunity to provide feedback on opportunities like this, but I want to make sure I'm in line with what VHA has provided as well, ma'am.
Okay. I wanted to, almost everybody is asked about respite care, and I wanted to ask briefly about this too. So, you know, we're in Ms. Chism's testimony, as I think the ranking member mentioned, that for 12 years she was unable to receive respite care. For 12 years she was unable to receive respite care. And then when she was finally able to receive it, she was told it would be, she'd have to give a 2-week notice or in order to get it. So, you know, having to rearrange her whole schedule and so forth, and perhaps miss a child's recital at school or whatever it might be that she needed it for. I just don't understand why this is happening. I do understand why it's happening. There's not enough respite providers out there. But I don't understand that if you've got a caregiver who is providing care for a veteran on a full-time basis, that for 12 years she is unable to receive any kind of respite care. So, you know, I would just want to hear your comments with regards to that. I want to know that, are the caregiver coordinators across the country reporting back to you how many people who are asking for respite care who cannot receive respite care?
Yes, ma'am. I think it's completely unacceptable on every level. Caregivers should have every opportunity available to them to take the respite that they deserve in order to take a break. So it's unacceptable. I think my staff does let me know, and I also meet with the caregivers to also find out.
Whoa, they let you know? Is this just sort of a casual thing? They'll call you up and say, oh, by the way, I have a couple of people out here that I can't provide respite care to? Or is it within your system to report that so you have the accurate data?
Yes, ma'am. It's within my system to report that we have the accurate data. We actually pay out the respite out of my program office, so I'm aware. That is what was brought to my attention, that we had such a low underutilization of respite across the country about a year ago. That is why we started the Respite Champions Initiative, so that we can increase that and make sure that our caregivers are getting that respite care they deserve.
And do you know how many respite people that you need to really satisfy the need out there across the country? The VA has this, sometimes has an issue of doing really well in one area, but not so well in another area.
Yes, ma'am. I think it really depends on the caregiver and the veteran. Some of them need 24-hour care. Some of them need care for 2 hours twice a week. So it really depends on the location and what the needs are of that particular caregiver and veteran.
Thank you. Ms. Chism also submitted in her testimony the issue around the Veteran Direct Care Program that the VA provides, and noted that this direct care is not really offered in certain areas, and it's in a very limited catchment area throughout the country. Can you speak to that, please?
Thank you, ma'am. My understanding of veteran-directed care, which, as you know, falls under geriatrics and extended care, I believe is now attempting to be offered across the country, but happy to take that back and get you further information from GEC if necessary.
Thank you. I think I would like to know when it's going to be offered across the country, and how long is that going to take for that to happen? I think it's a very popular program within the veterans, and certainly I think, again, the Elizabeth Dole Act addresses this. It addresses the respite issue, and certainly I think a successful transition for the legacy cohort and new veterans and new caregivers to move forward. So I'd like to have more specific information, and with that, I'll yield back.
Dr. Miller-Meigs, you're recognized for 5 minutes.
Thank you very much, Chairman Bost, and I thank our witnesses for appearing here, and some of the doctors were trying to answer the previous question for you, which my question is somewhat related to that, and you may have already answered it, Ms. Duke, but you're requesting $1 billion for high-cost drugs. I'm not going to go into the necessity for them because I think there's value in that, but it's a round number, and I believe you've described it as a guess. Do you think it'd be more appropriate to come back to Congress and request the amount of money once you have a more reliable estimate, or is it an estimate because you're anticipating growth in the need of those medications?
Thank you for the question. It's clearly the latter. It's the recognition that this is evolving and becoming a fiscal pressure within our purview. Not specifically the semaglutides, but pharmacy growth was part of what necessitated us coming forward with a shortfall. And so we wanted to make sure that we were transparent about the needs, and also not that we would have to make any decisions regarding pharmaceuticals based on having to make budget trade-offs next year. We always want to provide to our healthcare professionals what is necessary for the veterans' treatment.
And you estimated in your fiscal year 2025 budget that the growth of community care spending would drop from 14.8% to 12%. Now you're estimating that it will increase to 16.5%, and this difference accounts for $1.9 billion of your budget shortfall. Having taken care of my mother with Alzheimer's and my mother after my father's death, and he was retired military, why would you have assumed in your budget that community care would shrink? I mean, certainly in all of your listening sessions, it is extraordinarily popular. People, if they can, would rather be in their home with people that they know and with whom they have a relationship.
So it's not actually that we anticipate the program shrinking. It was the rate of growth. We've always anticipated that community care obligations would continue to grow. It was how quickly. And this was again, going back to post-Mission Act, trying to figure out what is the balance of the way to best serve veteran needs in light of the fact that we have facilities where we do and veterans live where they do. So this was a readjustment of the estimate of how much community care would need to grow to continue to provide veterans with the care that they are seeking.
Well, then I would have anticipated as a budget person, and who my brother-in-law is an accountant, that you would have kept the estimate the same rather than reduce it. And I just want to make sure that that's not a result of the VA trying to restrict community care access.
No, ma'am. We are committed to providing care wherever the veterans need.
Thank you. Dr. Richardson, the RAND report indicates that many caregivers feel unrecognized and unsupported by the VA. And I think you might have addressed this a little bit, but what immediate actions will the VA take to ensure caregivers are acknowledged as the key partners in veterans care? And that includes making decisions for veterans.
Yes, ma'am, I think that is a critical and crucial role for our caregivers. Oftentimes, our caregivers know more about the veteran than the veteran does him or herself. And so I agree with you. I think this is an opportunity for us to continue to collaborate across VA medical centers across the country, especially probably within primary care where we see most veterans come in first, and have that opportunity to make sure that we are recognizing those caregivers. One of the things that we've already done is caregivers have their own medical record when they are identified as caregivers in VHA healthcare system.
Is there a training that's required in primary care clinics for this relationship between the caregiver, the veteran, and the primary provider?
Yes, ma'am, there is. We have the Campaign for Inclusive Care that we partnered with several years ago with the Elizabeth Dole Foundation to ensure that caregivers are being included. But what I understand from what you're saying and what I've also heard from caregivers is that hasn't been effective enough, and we need to do better.
So speaking of the Elizabeth Dole Foundation, you noted in your testimony that several programs, including the VHA's Family Resource Coordination Program, have been delayed or limited since the announcement of the budget shortfall. Can you discuss the decision to limit the Family Resource Coordination Program, which in essence, family caregivers are saving the VA money, which is intended to connect caregiver families with needed resources from a phased implementation plan to a pilot program?
Yes, ma'am. I'm happy to connect with our partners in care management and social work on that question, as that falls under their purview.
Thank you to our witnesses, and thank you, Chair Bost. I yield back.
Representative Pappas.
Thank you, Mr. Chairman. I want to thank our witnesses for their testimony, and it's great to see a room full of veterans, caregivers, and advocates who are part of this conversation. We appreciate the work that you all do to help us figure out the right way forward. Dr. Richardson, can I ask you a question? We are so appreciative of what caregivers, family members, friends, and countless others who take care of our veterans do day in and day out. Unfortunately, some face a situation where a veteran passes away, and we need to ensure that there's communication with the individual so that they can get the help they need through VA's Office of Survivor Assistance. But we've heard from caregivers who are unaware of these resources and are often scrambling to access the information that they deserve. So I'm wondering if there are any warm handoffs to caregivers in this situation, and what greater coordination can you provide with VBA to make sure these individuals get the resources and help they need?
Sure, thank you for the question. So you're correct, the caregiver to survivor journey is in and of itself a challenging journey. We want to make sure that we have those resources and make it as smooth as possible for our caregivers who are transitioning to that role. There is a survivor and memorialship program that has been stood up under Care Management and Social Work this past year. We have a very close partnership with that organization, or within that program office, and we'll plan to continue to work with them. And I think we could do a better job on that collaboration piece as well.
Well, we know that caregivers often sacrifice financially, and on average, this is quantified to be $8,500 in out-of-pocket costs that caregivers incur every year, and $4,500 in earnings that they forego. So certainly supporting survivors as caregivers make that transition is incredibly important. What other financial help is provided to caregivers, any resources or supports that exist to make sure that they're able to make ends meet?
Sure. One of the things that we offer in PCAFC is financial and legal services for our caregivers enrolled in the program. So they have opportunities to take advantage of how to do living wills, living trusts, budget planning, those kinds of things, so that they can prepare for those potential things that may happen in the near future.
So I noticed a number of folks that are not participating in support services. I think on average it was 40 to 60%, depending on the age group of the caregiver. You talked a lot about the respite care and how utilization has increased since you've gotten the word out, but it appears that that was an issue where it wasn't a lack of demand, that you had to work on the supply side of things to make sure that people could get access to those services in a more efficient fashion. Are there other categories of support services that you are going to look to expand or increase, or just ensure that folks know about them? And I guess, what's the reason why so many are not taking advantage of these services?
Sure, thank you for the question. So there are several things that we're going to expand. I think one of the things that is important that we're going to expand this year is peer support mentoring. We know veterans appreciate the opportunity to meet with fellow veterans who have been there, done that, understand what they've gone through. It's the camaraderie, it's that automatic connection. And we know that happens in the caregiving community as well. So we have committed to having one peer support mentor for the caregiver program across the country in every VA medical facility. So that's one piece of it. The other thing that we've done is we hear various things from caregivers. While they love that opportunity to connect, they can't always come in person. So we have those virtual offerings. We have coaching into care, health and well-being coaches that really focuses on the individual caregiver and not what's the matter with them, but what is that matters to them. And so there's just a lot of variety of services that we offer both virtually and in person for our caregivers. And I think we need to continue to do a good job with that as we go forward.
You mentioned a new initiative around CPR training for caregivers. How's that going, and how is VA getting the word out to individuals about this new service?
Yes, sir, thank you. has gone exceptionally well. We have heard overwhelmingly from, because we survey our caregivers after the fact, and it has been very, very well received across the country. Today, we're at 70 medical facilities. Some of our caregivers can get actual BLS certification and CPR certification, excuse me, not BLS, but CPR certification. As we go forward, we want to have this at every VA medical facility across the country. I hope that we can do that this year. And in addition, like I said, we're doing that CPR Plus. So helping them with diabetic emergencies, falls, spinal cord injuries. We've also put together mobility transfer videos for them to watch and observe and learn from that as well.
Do you know how many individuals have gone through the program? Have taken the training?
Probably several thousand, sir. 7,000 to 10,000, I would guess. Quite a few.
Thank you. I yield
sir.
back.
Thank you, Dr. Murphy. You're now recognized.
Thank you, Mr. Chairman, and thank you guys for coming today. I really deeply appreciate the attention that we pay for our caregivers. I just still see a lot of patients, and oftentimes it's up to the wife or truly the oldest daughter that comes in and cares for their father or their mother, whoever the veteran is, and the sacrifice that they go through. So I want to follow up on one other thing about the semaglutides. You know, it's not only the VA's budget that's getting busted, it's Medicare's budget, it's private insurance companies' budget. And I think actually we need to have an American conversation as to dialing back this. This should not be, hey, I want to lose some weight, I get a drug. It should be really much more of a metabolic discussion. So it's going to be germane really to the entire country, not just to the VA. But it needs to be done, I think, in a much more academic and researched manner, not only for the sake of saving costs, but some of the deleterious effects that we talked about are some good effects, decrease in kidney disease and some of the other things. But I think it needs to be a national discussion, and hopefully it comes down to the VA, and hopefully we stop spending the billions of dollars on this drug that has become now kind of more of a cliche that you see folks on. So I will say this, Ms. Duke, is there anything that you guys have now had to deal with as far as more costs with the PACT Act with any of these instances that you're having to deal with?
So PACT...
As far as I'm understanding, that's really one of the major drivers for this huge deficit.
Correct. So the PACT Act both expanded eligibility, so veterans who previously we did not have contact with could come in for care. We've seen not just that we have new enrollees, but those who are already enrolled are now more likely to take advantage of the services because of the outreach that we've provided. And so that is what's driving that need for more care, both in the community and in the direct care system, which led us to revisit our budget estimates for the 25 budget.
Yeah, I mean, that's a good thing. Again, I think all of us on this committee are very concerned about the efficiency and the management of dollars within the VA system. You know, as I've said in this committee before, we spend 5 to 1 compared to the British healthcare system on our veterans. Not that that's wrong, but it's inefficient. We're not doing something right. We're not doing something that I think the private world would ever stand for. Dr. Richardson, just to getting back, because I know there are a couple of statistics here really that were bothersome. Only, I guess, half of the folks who are caregivers participated in programs offered by the VA. What's being done as far as education to making sure that these folks take advantage of the programs that are out there for them?
Sure, thank you for that question, sir. So as I mentioned earlier, we have hired an outreach specialist within the program. So we have partnered with our local VA medical facilities, and we try to attend as many national outreach events as possible. Veterans in the veteran community, when you know somebody who knows something.
Yeah.
And so if we can get the word out to just a few people, we know it will spread quickly. And we've seen that, sir. In the last month alone, in August, we had 9,600 applications come in our door, which is the largest volume of applications we've seen all fiscal year for PCAFC. So I have to make some assumptions that I hope that this outreach is working the way it's intended to.
Yeah, you can't make people sign up for stuff, but you can educate them that things are available. One other thing I want to follow up with, this committee and all of us are very, very concerned about suicide amongst veterans themselves, and I personally think we can do a hell of a lot more at the VA. We're not doing the job that we should. But then this translates also to caregivers, because there's so much depression, there's so much isolation, there's so much sacrifice that goes into them. Can you speak a little bit about what you guys are doing for the caregivers themselves? Because, you know, it's a common thing amongst people of my maturity that we are becoming parents to our parents. And this isn't just germane to the VA, but it's also other folks. And it is a life-changing event in transition. Not only we mourn the loss of a parent, but we also mourn the loss of our life. So can you speak to that a little bit with suicidal ideations and some of the other things, because I know it's much higher in caregivers?
Yes, sir, absolutely. Thank you for that question. So as I mentioned earlier, we have the virtual psychotherapy programs that are available to our caregivers now across the country. It's a simple referral from the caregiver support team at the local medical facility to get them into that appointment. Typically, we're getting them in and getting phone calls out within 5 days. I think that's one aspect, right? Not everybody wants traditional mental health therapy. A lot of people want non-traditional. A lot of veterans want non-traditional mental health therapy. And so that's the peer support mentoring where that comes in. Their ability to connect with somebody who is there, who's been there in that caregiving journey. I think we can do a better job of that. That's why we're going to put peer support across the entire country. The other thing is what we offer at the local medical facilities. Non-traditional, yoga, mindfulness groups. We have the coaching into care, the coaching health and well-being coaches that really focuses on what matters to our caregivers, because their caregiving needs are different than what the needs are of their veterans that they are caring for. And we have to address them individually based on what they need.
Yeah, this is a real problem. I just think, I see just on a regular basis, just the absolute burden that these folks have. So thank you for your attention. Mr. Chairman, I'll yield back.
Mr. Lansman.
Thank you, Mr. Chair, and thank you to all of our veterans and caregivers and advocates. It really is wonderful to see this room full, and we know how much you do and care, and we're grateful for everything that you do. I want to talk a little bit about the evaluation and data collection and some of the concerns I think we collectively share. This committee's heard me preach about continuous improvement, and I'm from Cincinnati. We have one of the best children's hospitals in the country, and it's a story I like to tell because I'm a proud Cincinnatian, but it's also instructive in terms of how to approach almost anything. They became the best or top 2, 3 children's hospitals in the country by becoming the best at getting better. They just developed a culture of continuous improvement. Everything got collected. All of the data, whether it was about a procedure or an experience from a parent or a child, and it was constant. And it's to this day. They measure everything, and they test, and they take chances, and they're not afraid to fail. And as a result, you get the best care in the country when you come to Cincinnati. So there is an evaluation component to everything we do, but an evaluation only tells us what happened, and not what's happening. It doesn't really tell us what to do moving forward the way data collection and continuous improvement does. So here's what's bothering me. You got 2 years of learning, but we don't really have any exposure to that learning. The evaluation was too restrictive, and now it's going through this rulemaking process. Don't have any real sense as to how long that's going to take. You don't need a rule change to collect data, correct? You don't need a rule change to survey your caregivers and veterans to find out what's working and what's not working, correct?
Correct.
You wouldn't need a rule change to use that data to then get better immediately at what you're providing for veterans and caretakers, correct?
Yes, sir.
So then tell me a little bit about the 2 years and why we don't know what you know in terms of everything that was learned and what's being asked as part of the rulemaking process. A, B, what is the role of continuous improvement, if any, as it relates to this work?
Yes, sir. Good question. Thank you. So I think 2 separate things as I'm thinking about this. One is looking at the specific eligibility criteria that rule is, and definitions that we've used to allow caregivers to apply and or get accepted or denied into the program of comprehensive assistance. In regards to what you're talking about, quality assurance and quality improvement, overall well-being, how the caregivers see our program and how we support them is, to me, different. And so what we've done to address that, we have a V-Signal survey that has gone out. It's been 2 years this September since we've sent it out. We've seen nice improvements. It's for folks enrolled in PCAFC and PGCSS. We have a 97 and 98% approval rate across the country with those numbers, so seeing good scores there. Does that mean that we're perfect? Absolutely not. It just means that we're taking the opportunity to get feedback on the care and respect. Do we help them with the support and services that they need? That's important to look at. The other thing that we've looked at are the processes in and of themselves. So I brought in a QM team, a quality management, quality assurance team. It's run by an RN. She oversees the process across the entire country. So we are reviewing charts, records, ensuring that it's standard and consistent. One VA is one VA, but it shouldn't be one VA is one VA. It should be that your experience at every VA may be a little bit different, but it's standardized and consistent no matter where you go. So they should have the same experience no matter which VA they go to. So that is something that we've also looked at, as very separate and different than the eligibility piece itself.
The other, so with my remaining time, it would be very helpful, I think, appreciating all the questions that we have, to get the data that you have.
Of course.
And everything that you've learned that should be made public. I mean, you know, I understand a lot of it has to do with eligibility, but there's still learning in there that would benefit us as policymakers.
Yes, sir.
Okay, thank you. I yield back.
Representative Van Orden.
Thank you, Mr. Chairman. Dr. Richardson, I got to say that you have been shockingly competent and transparent. This doesn't often happen in our committee hearings with the Veterans Affairs Administration, so I really appreciate it. I'm the longest-serving enlisted member of the military to ever be elected to Congress in the history of this country. I get all of my health care through the VA or community care. I'm 100% service-connected disabled veteran. I love the VA. I love my folks in La Crosse and Toma. I get these cool glasses there, and everyone that checks me in to clean in the place, to my primary care, they're awesome. Why don't I know about this program? You know what I mean? Is there like a flyer on a cork board that I'm missing when I go there to get my physical?
You should absolutely know about this program, sir. Yes, sir.
Okay. So do me a favor. Let's walk the dog on this. So you got a veteran that is eligible for this care, right? Safe environment, it's got a home and all that stuff, and they don't have debilitating psychological issues, or they're going to be violent. And then, so we have that, and then we got somebody that wants to provide care for this person, and we want someone that wants to provide care for the caregiver, correct? How do you figure that out? Like, how do you figure out who the caregiver is, like who's eligible for it, and then how do you figure out who's eligible to provide care for the caregiver?
Absolutely, sir. Great question. So oftentimes our caregivers don't recognize that that's exactly what they're doing.
Right.
I've taken care of my husband now for 15, 17 years and did not realize I was a caregiver until I became the executive director of this program.
All right, so that's an issue that we can actually work on, can't we? How is the compensation level for these caregivers and the caregivers of the caregivers determined?
Depending on the program, so the Program of Comprehensive Assistance for Family Caregivers is set in regulation to pay our caregivers enrolled in that program at a GS4 pay scale and based on locality. Yes, sir.
Okay, so can we reasonably just say if we're spending $5, this is an arbitrary number, and I'm an enlisted guy, so I can't really do math, so we're going to say if we arbitrarily spend $5 providing care, that we're really saving $50 at the end. Because having a veteran having to go into inpatient care or to a veteran's home or whatever is exponentially more expensive than having them stay at their home. And there's significantly less dignity, as Mr. Rosendale noted, 88% of folks want to do this, right? So here's my question. You got compensation up to $3,500 for PCAFC, right?
Yes, sir.
All right, that is $42,000 a year. The median income in the state of Wisconsin is $33,179. That's a solid job. Mm-hmm. So could we potentially look at saying, hey, let's look at the median income per state, and I know it's going to vary, I get it, and then tie the compensation for these caregivers and the caregivers of the caregiver to the median income of the state that they live in, so that they feel like, one, they're valued because they are, and two, they don't have to do this, taking the hit and all that stuff. And again, we spend $5 up front, we save $50 later. So to me, I mean, that's the advantage of being enlisted, dude. I mean, this is popped right out to me immediately. One, we got to advertise. I got to know that this is available because, believe it or not, even though I'm a roguishly handsome young man, I'm getting older. And, these programs, my wife takes care of me right now. She's a nurse and she stays at home. So I want my wife to know about this. I wanted you to know about it. Take care of your husband. God bless you for that. And thanks for your service in Fallujah, ma'am. Taking care of the Marines, Semper Fi.
Semper Fi.
I want people to know about this so they use it. And I want my fiscal hawk buddies to understand that by spending $5 up front, we're saving $50 on the backside. And so if you can, I'd love for you to come to La Crosse, Wisconsin. And I will host you there. I'll give you cheese curds. We'll do everything. I'm serious.
Yes, sir.
And let's do a clinic
Okay.
with signs saying, hey, if you're taking care of somebody, you should be compensated so they feel comfortable doing it.
Yes, sir.
I'll do that with you. That's a real offer.
Thank
Okay?
you.
I
Yes,
hope
sir.
you take me up on it. So
Yes,
God
sir.
bless you for your work, and you too, ma'am. I get Miss Duke is so happy right now. She's like, yeah, you've seen some of my hearings before. She's like, yes, he didn't talk to me. Okay, well. All right, sir, with that, I yield back.
Thank you.
It was so entertaining, though. So, Representative Basinski, you're recognized for 5 minutes.
Thank you, Mr. Chairman and Ranking Member. I want to thank the panelists for being here today. And I, too, just want to say thank you to the veterans that are here and their caregivers that took time out of their schedules to be here for this hearing, and the Elizabeth Dole Foundation for also being here. It's great to have you. I wanted to ask Dr. Richardson a few questions specific to the RAND report as it relates to rural access. I know Chairman Bost talked about that. He and I are actually from similar parts of the world, and also behavioral health. So Dr. Richardson, one of the findings in the RAND report highlights that rural veteran caregivers face significant challenges in accessing certain services due to the lack of broadband in their areas. In fact, the report notes that about a quarter of caregivers in rural areas did not have reliable broadband internet access in their home. So what specific steps is the VA taking to expand telehealth and in-person support services for rural caregivers, particularly for those who may lack that reliable access to internet?
Yes, ma'am. Thank you for the question. So they have something available to them called the Digital Divide. It's a consult in which we can provide those services, that device to them. Unfortunately, not as many people take advantage of that. And I think that's something that we need to communicate better and get out to them so that they know that it is available to them. We also find that because of post-COVID, that we still don't have a lot of in-person offerings. So that is something that we are pushing this year, that everybody will have in-person services available to them at their local VA medical facility. But I think the other thing that you run into with rural areas is it's a commute. Sometimes they have a long commute sometimes to get in-person services. So if we can get them connected to that digital divide, we can get them connected with those services, because Caregiver Support Program offers both virtual and in-person. And so it can be any service that they need. It could be 24, we have programs that are available to them at whatever time works best for them, because caregiving is not 8 to 4:30. So we just need to do a better job from that digital divide perspective, I think, to get that information available to them and let them know what is available locally and when, and make sure that we're meeting their schedules as it comes available to them.
And that kind of leads into my next question, and a little bit of what Congressman Van Orden was talking about is this awareness of the program. And in rural communities in particular, they really struggle with getting access to that information to be aware of these support services. Is the VA looking at anything, uniquely to help kind of bring more awareness into rural communities of the support systems you're providing?
Yes, ma'am, that's a great question. I think we've partnered with all the local medical facilities. So in every month of November is National Family Caregivers Month, and we require, as part of a best practice or our what we call the One Plan, is that everybody offers something in person. I always think there's opportunities to communicate better. I mean, I've been with VA, get my healthcare at VA now for 14 plus years, and I'm still learning so many things that VA has to offer. So I think it's just continued communication. We have VA Gov Delivery. We have, I think, over a couple 100,000 people that subscribe to our Gov Delivery, so we continue to send out those emails. Sometimes that works for our younger caregivers, doesn't always work for our older caregivers. So
Right.
we have to think about the various needs that they have across the country, too.
Okay, thank you.
Yes, ma'am.
And I have another question. This is more on behavioral health. The RAND report indicated high rates of stress and burnout among veteran caregivers. with many experiencing anxiety and depression. Could you speak to what specific mental health support programs is the VA implementing to address the unique needs of veteran caregivers?
Yes, ma'am. So as I mentioned earlier, we have a virtual psychotherapy program available to our caregivers that are enrolled in PCAFC at all 18 VISNs across the country. As a clinical psychologist of almost 20 years now and having spent time with the Marines, you have to think very differently about how we do care. And I think one of the things that we've realized is this doesn't exist anywhere else in the country, to my awareness, that we specialize in mental health treatment for caregivers. So we're looking at a few different things. We're looking at how to improve their quality of life. We're looking at how to lower rates of depression and anxiety. So we just trained our providers last week in ACT for depression. So we're trying to do evidence-based psychotherapy, train those 54 providers that we hired across the country to provide those services to ensure that they're meeting the needs of what we're seeing across the country, one. Two, the other thing is we have to measure it. I need to know where they started baseline and where they're gonna be when we're done with that psychotherapy, because I think mental health is it's a continuous journey. You don't have it one day and not have it the next, and 3 years later, you're fine. It kind of varies across that continuum. So we wanna make sure that we're looking start to finish. Is what we're doing effective and does it work?
Great, thank you. And just real quick in closing, I just wanted to mention an important piece of legislation that is relevant here that I introduced this morning alongside Congresswoman Brownlee, the Improving Veterans Experience Act. It's a simple yet important bill that would codify the Veterans Experience Office at the VA, which supports and enables VA to gather feedback directly from veterans, their families, and caregivers on how to enhance VA services. So we were excited to do that this morning. Great to have you here, and I yield back.
Thank you, ma'am.
Representative Self, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Richardson, you have pointed something out that I think is across the VA. Many of the veterans simply don't know the myriad of programs that are available to them. The education, I think, in the VA has got to improve in every area. So, Ms. Duke, I've got in front of me let's turn to the $12 billion. I have in front of me the $1.7 billion, about 14% of your $12 billion are in something called non-pay, okay? I've got that breakout in front of me. So it's an interesting category. Of the 1.7, you've got almost $2 billion are in other contractual services, and almost $1 billion in other supplies and materials and equipment go down. So we've mentioned the PACT Act. So this is kind of curious to me, because how does the equipment, let's just start there, how does the equipment go down when we know more veterans are coming because of the PACT Act?
Thank you for the question, sir. I would say that this is, first of all, this is a representative calculation for the purposes of generating our estimate. We, as always, leave our field directors in charge if they need to make an equipment purchase and let a contract lapse. They have that capacity to make those decisions in the medical center based on
Okay,
their
that's the decisions, but how in the world does VA writ large, you, say that you're going to buy less equipment? Let's leave that one and go to the other contractual services. $2 billion increase. Now, by the way, you said that about 16% is going to be through community cares. Did I hear that correct?
Yes, sir.
I thought that was low, because I thought I had seen a figure far larger than that, but we'll take your growth there in community services. So what are these other contractual services? And I'll get to my point after this.
There's a variety. This could include clinical services where we are using contract staff to supplement federal employees. This could be bringing in folks to assist with the work that needs to be done in the medical center. It really is kind of a catch-all. We can get you some more breakout if that's helpful.
Yeah, I'd love to see it, because I think this could be a slush fund. Let's just be honest. Non-pay, 14% of your $12 billion. I want to know what you're spending that on, because other contractual services doesn't give me much clarity. The rest of the categories here, transportation, rent and utilities, other supplies and materials, equipment, grants, insurance, those are things that I can get a hold of. Other contractual services sound to me like you're contracting things out. I want to know what those are. So let's go to your prosthetics. Almost $500 million is in the prosthetics area. No, before we even go there, you've already hired 5,000 new employees. No, you've hired 17,000 employees. Off the top of my head, 17,000. You've not told us what those 17,000 employees are. You've told us about the 5,000 that you are going to hire. When are you going to tell us about the 17,000 that you have already hired?
We can get you information regarding the breakout of our FTE on board.
Because 17,000 that you've already hired that we don't know who they are and what they're doing, I think 17,000 employees is a lot of employees that we don't know about as the committee. So now let's go to the almost $500 million in prosthetics. First of all, you're utilizing emerging technologies. And you may have to send these to me, okay, because I'm about out of time. So I want to know about the emerging technologies that are costing so much more. I want to know the growth in veterans, because as we wind down, why are more veterans accessing prosthetics? Where do you get your general inflation number? And then you mentioned, I think in your testimony, ongoing procurement challenges. That's something we can might be able to help you with. I want to know what your procurement challenges are specifically. So if you'll take those 4 questions, the emerging technologies, the number of veterans, where do you get your inflation numbers, and the procurement challenges, and we'll send this to you as QFRs. Thank you so much. Mr. Chairman, I yield back.
Representative Sheffield McCormick, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you so much to our caregivers for being here and all the hard work that you do. I'm actually very happy to be having this hearing today where we can spotlight our caregivers. Sometimes I feel like our caregivers are the strength behind our veterans who have served, and we don't do enough to actually make sure that our caregivers are taken care of. My father-in-law, he passed in 2018, and it was a tough moment for us to take turns trying to figure out how to serve him. From my other sister-in-laws, my brothers, we all tried to fill that gap. So I can't imagine being a sole provider or having to bear it every single day. So I thank you so much for being here. I also wanted to start off by asking one first question about the caregiver stipends. Do they earn Social Security credits, Dr. Richardson?
Good morning, ma'am. No, they do not.
And then I also wanted to highlight 2 of our guests who are sitting in the audience. I want to use this time to share 2 stories of caregivers sitting in the audience today, Stacy Howley and Ashley Lee. I commend them for both of their tireless advocacy and for their being here today. Stacy is an Elizabeth Dole Foundation Fellow, legal professional, caregiver, and mother to Army Sergeant Nathaniel Heath Price. I don't know how you do all that. But Nathaniel is a member of the 82nd Airborne Division who was deployed to Afghanistan. After a traumatic brain injury left Heath Price wheelchair-bound, Stacy had to balance her full-time job as a paralegal with the onerous demands of being a caregiver to her son. Like so many caregivers, Stacy experienced heavy financial strain. She exhausted her retirement savings and even began to sell her own blood just to make ends meet. In the face of all these obstacles, Stacy was never deterred. Rather, she continued to persevere, utilizing support services like the VA Respite Care Program, as well as the VSOs like the Semper Fee Fund and the Wounded Warrior Project. Thanks to the Elizabeth Dole Foundation, Stacy was informed of the Pillars of Strength Scholarship, which covers full tuition and fees for caregivers to injured veterans. She was accepted and now can complete her bachelor's degree, a longtime dream of hers. Next, I would like to talk about Ashley Lee, who was raised by her single father, Daryl, a Vietnam veteran living with ALS. Ashley became the sole care provider for her father after losing her husband in a tragic motorcycle accident. Ashley ended up having to quit her job to care for her father around the clock. Sadly, his condition continued to deteriorate, eventually requiring him to be placed on a ventilator. Due to the frequency in which Ashley's father was admitted to the hospital, she relied on housing provided by a nonprofit organization to be close to her father, often for 3 months at a time. Despite these immense challenges, Ashley has not wavered. She continued to pursue her PhD in psychology with an emphasis on research for our veterans with spinal cord injuries. Ashley hopes to one day work for the VA healthcare systems, and Stacy and Ashley represent the best of us. I cannot thank them enough for being here today and for sharing their deeply personal and likely traumatic stories with lawmakers like myself. Thank you so much for your service and the other members also. We must never forget the immense contribution caregivers like Stacy and Ashley make to our communities across the country. Dr. Richardson, I have one more question for you in this small amount of time I have left. The Program for Comprehensive Assistance for Family Caregivers is a vital lifeline to so many caregivers across the country. The program provides eligible caregivers with a monthly stipend to help make up for lost wages, as well as respite care for when caregivers need a much-deserved break. Given the important role this program plays for so many families, I'm concerned that the VA is continuing to drag its feet on publishing new regulations to refine the eligibility criteria for program participants, since pausing this discharge of legacy participants under the current criteria in 2022. VA has yet to propose new regulations, leaving many families in limbo. Dr. Richardson, why did the VA feel it was necessary to update the eligibility criteria back in 2020?
Yes, ma'am, thank you. So when the Mission Act of 2018 expanded the program for comprehensive assistance to veterans of all service eras, at that time, the program, VHA took a step back to look at the program as a whole, and that's how those October 1, 2020 regulations came to be. Today, we realize that we can do better. So VA has taken a step back these last 2 years and re-looked at the eligibility criteria and have submitted a proposed rule to the Office of Management and Budget this year.
And since my time is running out, if you could provide this answer later on, how can the committee work with VA to ensure that these regulations are expedited and that the veterans and their caregivers are aware of the new eligibility criteria for the PACFC program? Yes, ma'am. Thank you. I yield back.
Representative Siscomani, you're recognized for 5 minutes.
Thank you, Chairman. And thank you all for coming to testify today. I appreciate that. Supporting caregivers and ensuring VA programs function efficiently is something I'm proud to have a role here in Congress. I've introduced and co-led legislation with a comprehensive purpose. Also, for example, the CARE Act, and as well as the Veterans Caregiver Re-Education, Reemployment, and Retirement Act, which all aim to enhance the caregiver experience while bolstering programs already in place. Now, this has been talked about a bit during this hearing. I want to do a little more emphasis on the rural side of things. So, Dr. Richardson, caregivers have shared that even when they are approved for respite care, which gives caregivers obviously the opportunity to take a break from caregiving responsibilities, VA has been unable to provide basic care services in their place. That's been mentioned here already. But this is especially concerning for the rural parts of my district. What is the VA doing to address this significant issue and ensure eligible caregivers can actually receive the services they're entitled to, and veterans that they care for, they're entitled to as well?
Yes, sir. Thank you for the question. So 2 things. One, we've hired those respite champions across the country. They're trained at all 18 VISNs. They now have expertise in respite sources, respite funding, and because respite has been different across the country to every VA, we wanted to have experts at every VA medical facility that could understand what are the respite resources available to them regardless of where they live. That was the first thing that we did. And so that has been implemented, that is now in place. So we should have respite SMEs, subject matter experts, at every VA medical facility across the country. The second thing that we're doing is piloting this VDC pilot. And so we have 11 sites on board. Several of them are in rural areas from Chillicothe to Anchorage, Alaska, Togus, Maine. I think we have 6 of those sites are rural areas so that we can really focus on offering respite to those veterans duly enrolled in VDC and PCAFC who have high acute needs.
So I thank you for that. I want to just emphasize the importance of it, and I'm looking forward to seeing what the impact is from those, from the approach that you're taking now. The anecdotal evidence I hear at home is that they're not getting what they need, especially at the rate that they needed. So I'm curious to know also, when do you think you can expect some kind of measurement on how successful the efforts are being done.
Yes, sir, thank you. So I hope by the end of this year, after we pilot these 11 sites, I don't anticipate that it won't be successful. This is an opportunity for veterans to bring into their home who they want to care for them. So I can't imagine that it would not be successful, sir.
Well, I look forward to receiving that information, report, whatever it is that you can compile to show progress in this area. I would appreciate that.
Yes, sir.
Dr. Richardson, on back to you as well. When someone lovingly devotes all their time to a spouse or a family member in need of long-term care, we just heard from my colleague an example of that, they likely don't have the time to work and earn an income themselves. Being out of the workforce for long periods of time can heavily impact someone's ability to get back into the workforce. Does the program for the one you just mentioned, from Comprehensive Assistance for Family Caregivers, include any kind of support for reintegrating these individuals back into the workforce?
Thank you for the question, sir. Today, no, it does not.
We need to do something about that. Would including programs like this to assist with workforce reintegration be possible within the program, or would a new program be necessary for that?
Thank you for the question. I think it's a matter of partnerships across VHA, depending on, we know caregivers have very unique skills that most people don't have because of what they've done for their particular veteran. So they have a lot of skills, if you will, from bowel, PICC lines, bowel and bladder, those kinds of things. I think it could be a matter of seeing what we can do to integrate their skills into something meaningful, just as we do with, men and women who discharge from the military that have a particular background in medicine or a particular background in corpsmen, medics, et cetera. So I think there's an opportunity there to do something great.
Well, I don't want to put words in your mouth, but I'm sensing that you think it's a good idea, it's a good opportunity. We have these caregivers that took care of veterans, that they develop these skills that could be very valuable into the workforce as well. I think we have an opportunity here that we can work together on to either, again, find out, and if you could report back to me on this as well in the committee, if it's more possible to add this program to existing programs, or we need to venture out into something else. I'm very interested in that. Yes, the more people that are out in the workforce, the better it is for everyone. Getting a paycheck is not only good for the family and the economy, but for the soul as well, once they're back in there, and we need to make sure that we support them in that, after especially what they had gone through with the support they provided. So if I could partner with you on that and have your commitment to get something to us back here shortly, I would appreciate that.
Yes, sir.
Thank you. With that, Chairman, I yield back.
Mr. McGarvey, you recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Richardson, I want to thank you and your team for serving the more than 80,000 veteran caregivers participating in your programs. While many of the resources for caregivers are designed to be helpful, caregivers do find some of these services difficult to navigate, coordinate, and ultimately find them inaccessible. In RAND's recently published caregivers report, they found that military and veteran caregivers who are caring for veterans younger than 60 are at higher risk for depression. They're also less likely to seek care than their non-caregivers. And nearly half of caregivers report that they have no backup care, no one to turn to if they need support. Even with the Respite Champions initiative and empowering programs like veteran-directed care, utilization of needed in-home support services remains low. The VA can do better if it embraces customer experience and innovation. So take, for example, the Office of Geriatrics and Extended Care at VHA's innovation team, who are running the tech-enabled respite home care pilot that empowers aging veterans and caregivers to choose their own, they get to choose their own trained home care professionals, even their neighbor, through a technology-enabled co-employer model. The caregiver can take a break, and they can choose someone they know who has their back. Preliminary findings are promising. 60% of veterans participating in the pilot selected people from their existing communities to be employed, trained, bonded, and insured by the co-employer to provide home care support at a wage that was 50% higher than those offered by traditional home care agencies. Let me repeat that. 50% higher wages. And because there was less overhead cost for the employer, the cost to the VA was significantly lower than traditional home aid and respite services. So you've got comfort, you've got higher wages, you've got lower costs to the VA. I think this pilot demonstrated a significantly improved customer experience and increased rates of utilization for these services, all with an overall lower price tag to the VA. Better experience, lower price, higher wages. So Dr. Richardson, what plan does the VA have to roll out the tech-enabled respite home care pilot to other pilot sites or to scale up VA-wide?
Thank you for the question. I'm happy to take that back to our GEC partners. Certainly don't want to step on their toes and commit them to something I'm unsure of. But what I can say is it's an excellent program. We agree, which is why we're piloting our VDC respite pilot for those dually enrolled in VDC and PCAFC. I think you're right. I think veterans want people they know and care about to come into their home to take care of them, and we want to be able to do that for them as well.
Thank you for that. And if you, whatever you find out, let us know.
Yes, sir.
Because I think with this committee, you see it, there's a lot of bipartisanship here, because what we're doing is coming together and trying to find the best way to take care of the men and women who are willing to put on a uniform and sacrifice everything for us. And if we've got something like this, again,
Yes, sir.
higher wages, lower costs, better customer experience, we want to see that for our veterans. Another question is, how will your team prioritize patient experience and innovation moving forward? And how are you guys collecting feedback on some of the patient experiences?
Yes, thank you for the question. So several ways. We've been doing this since I came on board 3.5 years ago. First thing is, as a leader, you think you know what you know, but you really don't until you get down into the work of who actually does the real work around here. And that is our staff at the local medical facilities, and that is the caregiver who are on the receiving end of these services. So I do listening sessions across the country every single month with literally everybody, from my teams at every VA medical facility, either virtual or in person, and with caregivers across the country when I go to those sites. We have to look at that information, one. Two, we do a V-Signal survey. It's 2 years this September that we rolled that out across the country. And what we do is we have these opportunities for customer, I forget what we call it, but basically if we see something that wasn't favorable, they didn't have a good experience, we pick up the phone, we call that caregiver and say, what can we do better to earn your trust, and what can we do better to improve your experience in our program?
That's wonderful. Thank you so much, Dr. Richardson. And Mr. Chairman, I yield back.
Representative Gigan, recognized.
Thank you, Mr. Chair. Dr. Richardson, prior to serving in Congress, I was a geriatric nurse practitioner and have always looking for opportunities to support just other people who want to take care of and serve our veterans in our greatest generation. So how is the medical personnel shortage affecting caregiver training and support programs? And are there any plans for expanding something like scholarship programs or financial incentives or training for people like CNAs, LPNs, or geriatric-focused nurses at the VA?
Yes, ma'am. Thank you for the question. So caregiver support is primarily comprised of social workers, psychologists. We do have a few physicians that sit in, and nurse practitioners, occupational therapists, RNs, et cetera, at the centralized eligibility and appeals teams at the VISNs that render those decisions for the Program of Comprehensive Assistance. To my knowledge today, through CSP, we do not offer those, but I know VHA as a whole does offer those incentives and scholarships for those. I forget what they're called, ma'am, but happy to take that back and get that specific information for you.
Good, just finding ways to just incentivize people to go into that line of work. I think it's a very special, just special form of healthcare. And then on that same note, I remember in my primary care practice, and I represent Virginia's 2nd District, so a large veteran population, one of our challenges was just communicating to our veteran families what resources were available to them. I remember even things like the VA would build ramps or supply adult diapers or nutrition, and a respite care in a lot of situations. But even as a veteran, as a healthcare provider, it was hard for me to know what was available to our veteran families, and we would work with a really great and involved office manager a lot of times to liaison with the VA and find out, what that specific veteran family was eligible for. But how can we do a better job at not only communicating with families and caregivers, but communicating with providers, specifically primary care providers who touch a lot of that patient population as well?
Yes, ma'am. Thank you for the question. You're right. There's a lot of opportunities. As a veteran myself who been with VA now for almost 18 years, I struggle to navigate the system because there are so many things available, and we don't always know what's out there for us. I think there's an opportunity to collaborate with primary care to enhance that. I think one of the things I truly enjoy about our program is we do something called in-house wellness contacts, and it's our opportunity once a year to go into the veteran and caregiver's home to have contact with them. I have seen time and time again how our social workers and staff have identified needs for veterans that they didn't know was available to them. And to your point, shower chairs that lift them in and out of the seats that they sit in because they're unable to get in and out or transfer easily. So I think, that is something that I've seen historically now in the last 3.5 years, but I always think that there's an opportunity to do better on the communication piece to let veterans and caregivers know what resources are available to them.
Yeah, that's a good idea. There's nothing like going into someone's home and seeing specifically what their needs are, just doing a little bit of home health. It's a whole different world, and I think you can learn a lot more. But just working with the civilian side of the house too, because a lot of our veterans do still receive civilian primary care. And we had lots of drug reps come visit and different people communicating, what's new on the medicinal front, but maybe incorporating that too into visits to primary care practices that are civilian, just to educate providers. I think that would be certainly useful in a district like mine with large veteran population. Let's see, and according to the Census Bureau, 49% of living veterans are 65 and older, and 25% are between the ages of 70 and 79 years old. So what strains are you seeing on the existing caregiver support system as these veterans and their families register for VA caregiver programs?
So I think we see a couple different things depending on the service era of that particular veteran. I think when you start looking at your younger group of veterans, you start to see a lot of strain because the caregivers aren't just managing or taking care of a veteran, they're raising children. They're trying to work. They're trying to manage a household and kids' sports and all those different types of things. I think when you start looking at your potentially pre-1975 population of veterans, so your World War II, your Korean veterans, and your Vietnam veterans, you're seeing different strains on the family where the caregiver in and of him or herself isn't always capable of providing those personal care needs that that particular veteran needs. So now the daughter or the son-in-law or a family friend is coming in to step into the picture, and then they know even less about VA than maybe the spouse does at that time. So those are the challenges that I see in the program today.
Yeah, and I would agree with that. And we certainly know it's a sandwich generation a lot of times, taking care of our older adults and their younger families. It's a job that is thankless, and we need to be finding ways to incentivize our caregivers. We used to see the best patient outcomes when we had, especially family members that could be very involved, and it's not possible for every family, but as much as we can be helpful in incentivizing that and making their lives easier, providing the benefits that they're entitled to, we're happy to help, I know, from this committee. But thank you for all you do, and I yield back, Mr. Chair.
Representative Kennedy, you're recognized for 5 minutes.
Thank you, Chairman. Dr. Richardson, thank you for your testimony and your leadership. Ms. Duke, thank you for your testimony and leadership as well, and for your service to our country. And to all the veterans that have joined us here today and those watching, for your service to our country as well. I'm, too, like my colleague, a healthcare practitioner. I'm an occupational therapist. I'm happy to hear you just mention occupational therapy is under your purview. I'm the son of a nurse, a grandson of a nurse, and the son of a father who received life-saving medical treatment at the VA hospital in Buffalo when I was a young boy in the early 1980s. So obviously it's very personal for me and my family, as it's personal for all families across our country, the work that you're doing. That's why it's so important, your testimony here today, and how we can work to get it right. I want to go back to what one of my colleagues brought up in the $12 billion fund for new hiring. My colleague mentioned new hires, and I think, Ms. Duke, this is for you. My colleague brought up new hires coming in at 5,000, potentially 17,000. The question I have, because of the data that I've seen, is that there's actually been a decrease in employees across the system since the PACT Act was put in place. Is that accurate? Has there been a net increase or decrease in employment across the board at the VA?
So the short answer is there has been an increase when we expected it to be a decrease, and that is why we are communicating the need for additional resources. We had expected coming into 2024, because we had been so successful hiring up last year, that we would be able to keep FTE coming down and still continue to provide the same quality of care. And what we've seen from our front lines is that that was not feasible. And so because we never had a hiring freeze, we now see our staffing going up. The 5,000 is what we are anticipating net across the system growing in 2025, which again is just to enable our field to continue to bring on what's necessary.
But what I'm asking is not forward-looking, but to this point. Since the PACT Act was passed, has there been an increase or decrease in employment across the system?
Increase.
There has been an increase. So those 5,000 new hires you mentioned have already been hired, or 17,000 have already
They
been
have
hired?
not, but we were able to grow in response to the emergent needs that we were seeing.
And the issue is that you cannot pay them with the amount of appropriation that has been given to you thus far.
That's correct.
Okay. So there is a $12 billion hole, is that accurate?
$12 billion in 2025. Yeah, but that includes resources that we're spending in '24 that we didn't think we would need to.
Right. So an increase in employment, an increase in need from veterans that, thankfully, with the leadership of the community and Congress and the President, has enacted the PACT Act to broaden healthcare services for our military heroes. But the funding is not there, so it is unsustainable at this point. You need that $12 billion.
That is our estimate as of this time.
Well, I would argue that Buffalo, New York, that VA hospital that helped save my father's life 40 years ago, is a shining example of the need for more resources. The nurses just recently were out on the picket line calling for more resources. They are saying that there's what amounts to a hiring freeze, even though you just said there isn't a hiring freeze, because it takes 9 months to onboard an individual because the funding isn't there. And so I just want to make the point, and maybe you can elaborate on it, that the promise of America to our veterans to don the uniform is not being kept if the funds are not being put in place in order to provide for the care that they're depending on.
I would say that the reason we came forward with the shortfall was because we did not want to be in a situation where we did not have adequate resources to continue to meet that promise to our veterans across our system.
We have work to do. Thank you.
Gentleman yield back. Well, thank you, Dr. Richardson, and thank you, Ms. Duke, for testifying today. I know it was kind of a long, but you are excused, and we appreciate you being here. Once again, Dr. Richardson, Semper Fi. And then if our second panel of witnesses can approach the table and take their seats whenever they're available. All right. On our second panel, we have Dr. Rajeev Ramchand, a senior behavioral scientist and coordinator of RAND, Epstein Family Veterans Research Institute. Got all that out, right? And we also have Mr. Steve Schwab, the CEO of the Elizabeth Dole Foundation. We have Ms. Vanessa Chism, and Elizabeth Dole Caregiver Fellow. and Mr. Troy Broussard, State Director of the AARP, and Mr. Jonathan Pruden, Special Advisor to the Chief of Staff for Warrior Care at the Wounded Warrior Project. Now, I now recognize Dr. Ramchand for 5 minutes to deliver your testimony.
Chairman Bost, Ranking Member Takano, and members of the committee, thank you for inviting me to testify. My name is Dr. Rajeev Ramchand, and I co-direct the Rand Epstein Family Veterans Policy Research Institute at RAND, a nonprofit, nonpartisan research organization. Yesterday, RAND released America's Military and Veteran Caregivers, Hidden Heroes Emerging from the Shadows. I had the honor of leading this study. The study estimates that there are 14.3 million military and veteran caregivers. This estimate surpasses past estimates of military and veteran caregiving in the United States. Many people caring for those in need of support do not identify as caregivers, but previous research has largely relied on a person identifying as a caregiver in order to be counted as one. Our updated approach relies on people describing the caregiving tasks they perform. We are including caregivers who may not identify as such. This may include spouses caring for aging parents, individuals caring for their friends with mental health conditions or substance use disorders, or non-family members who may take on caregiving roles for their friends and neighbors. Many military and veteran caregivers see value in caregiving. As a caregiver taking care of a veteran friend told us, you feel like you are doing humanitarian work. You learn from their personal experiences, from their life, but there are costs to caregiving as well. In my testimony today, I'm going to describe highlights from our research that demonstrate the diversity of military and veteran caregivers and those they are caring for, as well as the implication this diversity has for policy. I'm also going to quantify the emotional and financial costs of caregiving and provide policy options to address these issues. Military and veteran caregivers are not a monolith. One important distinction we found was that 26% of these caregivers are caring for service members and veterans aged 60 and under, and these caregivers and their experiences are very different from those who care for someone over age 60. Those caring for younger veterans and service members are most often spouses, neighbors and friends, or family members such as siblings or aunts and uncles. In contrast, the largest group caring for older veterans are adults caring for their parents. Those spouses and friends each account for a significant proportion as well. Many military and veteran caregivers are caring for individuals with cognitive, mental health, and substance use diagnoses. Between 40 and 60% of military and veteran caregivers reported that their caregiving entails helping the veteran cope with stressful situations, manage sudden changes in mood, or avoid triggers of anxiety or antisocial behavior. But these tasks only scratch the surface of what these caregivers do to help service members and veterans struggling with emotional and behavioral issues, including thoughts of suicide. The problem is that many policies and programs overlook military and veteran caregivers to those with mental health and substance use conditions. Eligibility requirements are often based on activities of daily living, such as helping a person bathe, or instrumental activities of daily living, such as grocery shopping or housework. But these may be inadequate for describing what many military and veteran caregivers do. This has implications for policy. First, we must ensure that policies and programs directed to support military and veteran caregivers, including those run by the VA, support those caring for individuals with mental health and substance use diagnoses. Second, we must promote programs to caregivers in ways that do not require them to identify as caregivers in order to partake in them. Caregiving takes an emotional toll. 43% of military and veteran caregivers to those aged 60 or under meet criteria for depression, nearly 4 times that as non-caregivers. Among the top barriers they report for not receiving mental health care or not having time for such care, and being worried about the side effects of medications or being hospitalized if they were to admit certain things, such as past suicidal thoughts. Our report makes strong recommendations to increase mental health care to caregivers and their families. As you heard, VA is piloting a novel approach for those who are doing it for the small subset of caregivers who qualify and are eligible for the PCAFC. But there's more needed, especially outside of VA. Expanding telehealth may increase access to mental health care for more people, but its benefits will only be fully realized when interstate licensure agreements are worked out. Integrating mental health into primary care, like models such as collaborative care, is also a critically important step. If you compensated military and veteran caregivers for all the hours of caregiving they perform, it would total well over $100 billion. But most caregivers are not paid for their work. There are different approaches to help address this financial strain. We recommend that programs serving caregivers expand outreach to help them identify existing sources of support, such as SNAP or WIC. But we also recommend that Congress seriously consider tax credit options for caregivers. Research has shown that other tax credits, such as the Earned Income Tax Credit or the expansion of the Child Tax Credit during the height of COVID, helped lift millions out of poverty, and a caregiver tax credit might result in similar results as well. Thank you for your time, and I look forward to your questions.
Thank you, Doctor. And Mr. Schwab, you're now recognized for 5 minutes for your opening statement.
Good morning, and thank you, Chairman Bost, Ranking Member Takano, and members of the committee for the opportunity to testify today. My name is Steve Schwab, and I am CEO of the Elizabeth Dole Foundation, a national nonprofit whose mission is to strengthen and support military and veteran caregivers. Before I begin, I want to recognize the more than 60 Dole Caregiver Fellows that we have in attendance today from all across the country, as well as many more watching online. They have taken precious time away from their caregiving duties to be here, and simply put, their value to their loved ones and the VA and this nation cannot be overstated. I'd also like to thank and recognize former Secretary Bob McDonald for being here today and for coming on board as the Foundation's new board chairman. Yesterday, the Foundation was honored to welcome over 600 guests to our 9th annual convening, launching the new RAND report just outlined by Dr. Ramchand in his testimony. This landmark research, thanks in part to our friends at Wounded Warrior Project and AARP, reflects what we see every single day at the Foundation, as well as in the moving testimony that you'll hear soon from Vanessa Chism. We could not be more proud of Vanessa and her family for being willing to share her experience and theirs to help others. I want to thank Vanessa, Cody, and the Chism family for being here today. While I offer a detailed outline of EDF's takeaways from the RAND report in my written statement, I want to focus today on 2 grave areas of concern for our community. First, addressing the current Veterans Health Administration budget shortfall. While we appreciate that Congress acted quickly to address the funding shortfall for the VBA, the challenge still remains to fund VHA at appropriate levels to ensure veterans and their caregivers receive needed and earned care and services. While the VA Caregiver Support Program represents a relatively small part of the VA, the impact of the shortfall in this program offers a picture of the overall impact at the agency level for veterans and their caregivers. We will endanger veterans and caregivers by abolishing frontline vacant positions, by instituting hiring freezes, or a lack of clinical providers and social workers, and budget cuts to vital programs like respite that we're just finally starting to get traction, as we heard from Dr. Richardson. In addition, prior to the identification and announcement of this shortfall, multiple new programs impacting caregivers, veterans, and survivors were on track for full implementation. The Veteran Family Resource Coordination Program, the Survivor Assistance and Memorial Affairs Program, and the lead social workers at the VISN level were all delayed. These programs and services are intended to connect caregivers and families with resources before a crisis occurs and could promote cost savings, as we've heard this morning, in addition to the added peace of mind for the caregiver. Additionally, the Foundation and every other major veteran service organization strongly support the passage of H.R. 8371, the Senator Elizabeth Dole 21st Century Veteran Healthcare and Benefits Improvement Act. As many of you know, this omnibus bill includes the Elizabeth Dole Home Care Act, which has numerous provisions directly impacting veterans and caregivers. Most notably, the legislation would remove the 65% expenditure cap on VA provided in the home and allow our most vulnerable veterans and caregivers the support they need to stay with their loved ones. We thank Congresswoman Julia Brownlee for her leadership in introducing and fighting for this legislation. While the passage of this bill is a top priority, the Veterans Omnibus Package, to which Senator Dole also proudly lent her name, includes numerous additional provisions important to caregivers and veterans. Excuse me. Including grants in the community to provide, to provide much-needed mental health care to veterans and their caregivers, a pathway to advocacy, long-awaited pilot program for assisted living services, significant benefits for survivors, which has come up repeatedly this morning, and finally, enhanced access to in the community for those whom it has been determined for their clinician is in their medical best interest, and it enhances access to rehabilitation for veterans in need. I also want to remind this committee how vital it is that we grandfather our 14,000 legacy caregivers into the PCAFC program. This committee has championed landmark legislation such as the PACT Act and the Compact Act that significantly increase the number of veterans receiving VA care, benefits, and creating additional strain on the VA system. We understand there needs to be a conversation about the balance of community care and direct care, but we want to strengthen the VA and ensure staffing is sufficient for the need. But until a plan is in place, the access to care provisions in the omnibus provide a lifeline to veterans in need and the caregivers who advocate for them. Many of the challenges outlined here and in the RAND report can be addressed through continued oversight and legislative initiatives as I have outlined. Specifically, the omnibus package would provide in many cases immediate relief to those in need. We urge members of the House to reach out to trusted veteran, caregiver, and survivor advocacy organizations to hear their perspective on this legislation and ensure its swift passage. Veterans and caregivers have been waiting for 2 years for Congress to take action on many of the provisions in this bill, and they simply cannot wait any longer for its life-saving and life-changing provisions. Thank you, Mr. Chairman, and I look forward to your questions.
Thank you, Mr. Schwab. Ms. Chism, you are recognized for 5 minutes for your opening testimony.
Chairman Bose, Ranking Member Takano, and members of the committee, thank you for allowing me to speak today. I am sharing my story today, representing millions of other caregivers who are experiencing similar struggles, yet they bravely tend to our nation's heroes every single day. My name is Vanessa Chism. I am the wife and caregiver for my husband, Cody. We were high school sweethearts, marrying soon after graduation. In 2003, he decided to join the U.S. Army as a combat medic. While at our third duty station, he deployed to Iraq. And in December 2008, he came home. I naively thought he was unscathed from the atrocities of war simply because he was coming home without being medevaced out of the combat zone. The moment I saw him, I knew I was wrong. Ultimately, my husband was medically retired from Walter Reed Army Medical Center in 2011, after spending almost 2 years in the WTU there, with a diagnosis primarily of PTSD with bipolar disorder. My husband was appropriately diagnosed in 2012. It was determined that my husband's experiences in combat likely caused PTSD, moderate TBIs, and seizures. While suspected for many years, it wasn't until 2024 that he was diagnosed with chronic traumatic encephalopathy by the VA, causing continuous neurological decline. It has taken me 15 years, collegiate education in psychology and behavioral neuroscience, 6 VAs, and multiple private physicians to even begin to understand his actual diagnosis and the care and services available to him and our entire family. His daily life is afflicted with chronic suicidal ideations, migraines, frequent seizures, episodes of psychosis, chronic pain, and cognitive impairment, leaving him unable to care for himself independently. While he is still here physically, I have lost who my husband once was. Our family endures the ever-changing neurological decline resulting from traumatic brain injuries, but we have learned to fight and learn to advocate and prevail as a family. There are programs within the VA established to assist families like mine. However, accessibility is the problem. I have been enrolled in the PCAFC program since 2012, currently a legacy participant. On November 5th, 2021, despite VA assessors stating multiple times that my husband is not capable of caring for himself, I received notification that he was being discharged from the program because he would not need continuous care for more than 6 months. I am currently among the approximately 14,000 other legacy participants in the pause, waiting for the VA to disclose our fate, which leaves us all vulnerable and unsure of what the future holds. Enrollment in the PCAFC program provides eligibility for respite care, yet I have never received it. I requested respite care multiple times at multiple VA facilities. While approved, there were no available providers. I was successful in receiving respite care once. It was through the Elizabeth Dole Foundation. The respite provider drove and assisted my husband with obtaining medications from the VA and then took him with his service dog to a dog park to play. The simple ability to not have to worry for just a few hours is invaluable. Currently, my respite is provided by my incredible children. They too have dedicated their lives to being their caregivers to their father. Without apprehension, they step in to help, whether that be driving him to the store and making sure he remembers why he's there, knowing what to do when he has a seizure, understanding when plans have to be canceled, or monitoring their dad doing simple daily tasks. Both of my older children have had periods in their lives where they needed therapy services to help them. Thankfully, Wounded Warrior Project helped me ensure all barriers were removed so that they received care. While I recognize the challenges of this life, I like to focus on the positives. All 3 of my children are incredibly kind, compassionate, flexible, and always dependable. These are characteristics they not only present within our home, but throughout our community. There are sacrifices made, but they have their dad at home with them. That can never be replaced. Veteran Direct Care is another beneficial program. However, I have found that staff at VA healthcare facilities are not fully trained regarding the VDC program, and it is often only available in limited catchment areas. I have had to inform social workers at VA facilities of the VDC program and explain the process for eligibility. VDC could only allow me to directly hire trusted individuals who are familiar with Cody's needs and provide me with respite care. Yet, I have been unsuccessful in accessing this program. VDC could be an asset to me and other caregivers who need and deserve a break so we can be at our best when caring for our veteran. Another beneficial yet challenging to access program is the Community Care Network. For example, when referred to a community care podiatrist, we found multiple hurdles attempting to access care. The podiatrist provided exceptional care, yet she was not permitted by the VA to provide something as simple as a walking boot to improve his mobility. After waiting for months for the VA, I spent hours of my time to discuss with the VA how to fix this problem. The delay was a result of inaccurate paperwork. The unnecessary back and forth was more costly for the VA and detrimental for Cody. I became my husband's full-time caregiver at 26, and I am now 41. Being my husband's caregiver is a choice I make. And 15 years into this, I am fully aware of the sacrifices I have made and will continue to make. With the appropriate support structures in place, I can be a better caregiver for him every day. I am no longer naive. I know that there may come a day where I can no longer care for Cody in my home. We should all be allowed to make the decision that is best for our families, with the full support of the VA. My husband chose to defend our country without hesitation, unknowing the consequences of war that would impact the rest of his life. Despite any disabilities and accommodations, if he chooses, my husband deserves to be involved as much as possible in our lives. But we can't give him that choice without your help. It is this country's responsibility to ensure we provide our veterans with unwavering, easily obtainable support. Because of my lived experiences and experiences of other caregivers, I would like to make the following recommendation. The immediate passage of H.R. 8371, because it addresses many of ours and other families' challenges. Grandfather all current PCAFC legacy participants. we have proven we are eligible for this program. Expansion of complex post-acute neurological treatment within VHA. Provide easily obtainable case management or care coordination services for veterans with complex medical needs. Thank you all for the opportunity to share my story. I share these personal details with you not looking for sympathy, but to ensure significant, positive, impactful change, lessening the load for veterans and their caregivers across this nation. Thank you, and I look forward to questions.
Thank you, Ms. Chism. Mr. Broussard, you're now recognized for 5 minutes.
That's right. Thank you. Chairman Bost, Ranking Member Takano, and members of the committee. My name is Troy Broussard, and I'm the State Director of AARP Kentucky. AARP, which advocates for more than 100 million Americans age 50 and older, including the over 430,000 Kentuckians, appreciates this opportunity to provide testimony to today's hearing. But I will tell you, it's my distinct honor to also have the opportunity to testify before my very own Member of Congress, Representative McGarvey, out of District 3 in Louisville, Kentucky, so it's an honor to be here. I'm also a proud Army Desert Storm veteran. For me, being a veteran embodies resilience, sacrifice, and a deep sense of duty to my country, our country. You know, prior to becoming the State Director of AARP Kentucky, I led AARP's National Veteran and Military Families Initiative, and worked very closely with the Dole Foundation. Helping veterans allows me to give back to those who've shared a very similar situation that I have in the military, and it paved the way for me to serve my country and my community. It is a way to honor the service that to ensure that they receive care, compassion, and recognition that they deserve. The vast majority of veterans who need care are getting it at home, provided by their loved ones. That may be as simple as driving someone to the VA for a doctor's appointment, managing appointments, or finances, or more complex things like helping someone get dressed, bathe, or anything along those lines there. Increasingly, these tasks are becoming more and more medical, changing dressings, catheters, tube feedings, operating equipment, and more. We call this family caregiving. And there's more than 48 million people across our great country who are doing this work each and every day. These caregivers are truly the everyday heroes, the ones that's sitting behind us here and out listening to this as well. I'll give you one, a hero like Terry, who lives in Indiana, who cares for her husband, who served in the Air Force. She received some support from VA and has used AARP's caregiving free resources. At the same time, she faces challenges such as healthcare providers being dismissive and not appropriately communicating to her about her husband's care. Family caregivers are holding up their families and America's long-term healthcare system. While it's a labor of love, it can also be overwhelming both personally and financially. One out of 3 caregivers are spending at least 20 hours a week on caregiving. So it can also have an impact on their jobs as well. We at AARP have found that family caregivers spend an average of 26% of their income annually, or $7,200, on caregiving. But those who care for our veterans spend about 50% more than $11,000 a year. We are doing what we can to help. We have free resources at AARP, information and tools to help caregivers, and that can be found at aarp.org/veterans. We try to make sure that veterans and their families get access to benefits that they're eligible for and know what help is out there. But we need more than a website, okay? The reality is, without family caregivers, more Americans would have to rely on government programs for their care. We estimate that value of care being provided is about $600 billion a year. That's money taxpayers aren't spending because families are doing it for free. We are so thankful for this bipartisan, bicameral Assisting Caregivers Today caucus, or the ACT caucus, co-chaired in the House of Representatives, co-chaired by House of Representative Jen Kiggins and Debbie Dingell. We are hoping that Congress will recognize the incredible contribution of caregivers and the money they are spending out of pocket to advance bipartisan legislation to give a tax credit to help those offset those expenses. We can do more to cut the red tape between Medicare, SSA, VA, and to make it a little bit more easier for caregivers. You know, we're seeing great strides in states, other states already. Oklahoma and Nebraska have passed tax credits for caregivers already. In Kentucky this year, my team successfully fought for increased access to broadband, increased access to home care and Medicaid, and increase in funding for senior meals. We have also worked very closely with our Kentucky Department of Veteran Affairs to share resources, specifically like our military caregiving guide that provides caregivers step-by-step instructions on how to help them through that process and to the special needs that are veterans. In closing, I want to thank you all for bringing attention to the millions of everyday heroes are caring for their loved ones who served our country. They need and deserve our support, common sense solutions, and that meets their needs. And AARP is proud to provide support with them for advocacy resources and research. Thank you.
Thank you, Mr. Broussard. Captain Pruden, you are recognized for 5 minutes for your opening statement.
Thank you, Chairman Boss, Ranking Member Takano. Opportunity to speak about the tremendous contributions of the caregivers providing care and support to our nation's wounded warriors. Caregivers play a critical and indispensable role in the lives of these veterans, and many have risen to the occasion with love, pride, boundless energy, and unwavering commitment. But many have faced mental, physical, and financial hardship along the way. We are grateful for the chance to speak on those challenges today. Our perspective is informed by over 20 years of delivering programs and services to wounded warriors. Caregivers have been by our side every step of the way, including my wife, Amy. Caregivers play a key role in how we serve through our Independence Program, which helps veterans with moderate to severe brain injuries, paralysis, or neurological conditions to live more independently and a better quality of life. Caregivers have also been crucial partners in how we provide care through our complex case coordination program, which leverages VA, DoD, and community resources to rapidly triage and address the most urgent needs of our veterans. And caregivers have shaped our calls to action before this committee and Congress. Caregivers drove our advocacy for the program of Comprehensive Assistance for Family Caregivers, which launched in 2011 and has grown to play a meaningful role in the lives of more than 60,000 caregivers in 2024. Caregivers helped set a vision for how we tested innovative long-term planning through the Assisted Living for Veterans with TBI pilot, which ran for 10 years and provided insights on how we can better care for younger veterans who require supportive living environments. And caregivers, including many of those in this room, are a key part of our strong support for Elizabeth Dole 21st Century Veterans Healthcare and Benefits Improvement Act. This bill includes many provisions that would support veterans and caregivers, and I'm pleased to highlight 3 of those today. First, VA has many programs to support veterans, but they can be hard to navigate and aren't uniformly available or funded across the country. Caregivers are often left confused and frustrated when they try to help their loved ones. The Dole Act would require VA to expand access to home and community-based services like veteran-directed care to every VA medical center, and also require VA to counsel veterans and caregivers about these programs before they have to leave PCAFC. Second, caregiving often takes a huge emotional toll. RAND's recent survey shows that 84% of post-9/11 caregivers show high levels of perceived stress, which can contribute to depressive thoughts and suicidal ideation. Sadly, many aren't connected to the support they need. The Dole Act would authorize VA to provide grants to organizations that support caregiver mental health and well-being. It would also help mitigate some of the stress associated with caregiving by ensuring better access to respite care, as many of the members here today have discussed. Third, post-9/11 caregivers are aging alongside the veterans they support. As life circumstances change over time, caregivers who are parents, children, and adult siblings may be more likely to seek other care arrangements. Finding alternative care solutions for veterans, particularly those with the greatest needs, must be a priority, but it will take planning. The Dole Act highlights one avenue through a pilot to provide assisted living services to eligible veterans and assess their satisfaction with the program. Most veterans and caregivers want to remain at home as long as possible, but we owe it to them to have suitable options in the community when staying at home is no longer an option or is not feasible or safe. Beyond passing the Dole Act, Congress can support caregivers by helping them navigate complex systems of care. VA has tremendous resources, but they aren't always easy to find or understand. Other federal, state, and community resources exist, but they aren't clearly connected. We can start by empowering VA to create a system that helps centralize care coordination and patient advocacy, particularly for those with the most complex needs. Caregivers often become the best advocates for their veterans, but the fact is, these veterans still need consistent, coordinated care from VA. Congress can also help caregivers plan for their financial future. Based on Wounded Warrior Project's annual survey and RAND's recent research, post-9/11 caregivers show substantial out-of-pocket costs associated with caregiving. Caregiving duties can also greatly impact the caregiver's ability to build and maintain a career, placing them in even deeper financial uncertainty. To those ends, we support the Veteran Caregiver Re-Education, Reemployment, and Retirement Act, and we encourage more oversight to help provide a clearer picture of how VA and other federal agencies can support caregivers now and into the future. It's also a fresh reminder for VA and Congress to reaffirm their commitment to caregivers by resolving the financial uncertainty and emotional anxiety created by the current regulatory pause in the review of PCAFC. Thank you again for the opportunity to testify, and I look forward to your questions.
Well, I want to thank each of you for your testimony. I appreciate that so much. Mr. Chism, I want to thank you for personally putting your story out here. I know that's not an easy thing to do, and for showing your family and what you're facing, to be the face of the many others that are in the crowd and across this nation. And so we're going to go to questions, and I'll recognize myself for 5 minutes, and then I'll go to Mr. Brownlee. Mr. Schwab, the Elizabeth Dole Foundation has strongly supported the Elizabeth Dole Act and the bills that would support caregivers. What would be the most immediate impact on caregivers if the Dole Act were passed?
Thank you for this question, Mr. Chairman. We've talked a lot this morning about the Elizabeth Dole Home Care Act, and while that is a major priority of the foundation, it is not our only priority. We want to make sure that folks understand the other legislation that's part of the omnibus bill. A lot has been said about the terrific and impactful ways the Home Care Act will impact caregivers, and Vanessa talked about some of them. I want to stress the fact that the reimbursement rate for expenditure caps and non-institutional care will go from 65% to 100% is life-changing. We have caregivers who are providing support, for instance, with loved ones that have ALS, that are going into debt, supporting those in-home costs. Expanding VDC is critical. It's a big part of the Home Care Act. We've talked about the necessary mandate around warm handoffs. That's not happening at the VA right now. But I also want to talk about some aspects of the bill that are beyond the Home Care Act. There's an assisted living pilot program that's essential. Access to care provisions. We've heard from a lot of members this morning and from Vanessa about how access and navigation continues to be a major issue. We've talked extensively about the lack of mental health and mental health care for caregivers. The reality is right now that the programs that are offered are to the PCAFC program participants, which is a small percentage of the overall caregiving population, and the omnibus bill would allow for expansion of that. And we've also talked about the value and the transition, the hard transition from caregiver status to survivor status, Mr. Chairman. This bill, the omnibus bill, has survivor provisions in it that are really vital to the community as well. So the impact is gigantic.
Can you kind of share what the biggest obstacles you face when trying to access VA and support services such as respite care?
Thank you for the question. My biggest obstacle when trying to access that is actually the VA. I have found the VA employees are not educated in the programs that the VA offers, nor do they understand the criteria for caregivers to receive these support services. I have actually experienced a VA social worker telling me that I would probably figure it out before they would when requesting assistance, and I never heard from them again. And I did figure it out. There is also a huge issue with staffing within VHA facilities, resulting in their inability to provide appropriate health care to our veterans and support services, especially respite care, to our caregivers. I know we discussed the budget shortfall we're all aware of, and I do believe that that is having an impact. I would like to know the extent of the impact that that's going to continue to have on us. And we switched my husband's care over to the Baltimore VA for respite care. There, I was told for the first time ever that I could get respite. However, I need to request it at least 2 weeks in advance. That's not something that's really reasonable in my life. With the way I don't know if my husband's going to have a traumatic seizure and be in the hospital that day. I don't know what's going to happen. So I provide around-the-clock supervision for him, and I'm simply requesting occasional assistance. When I did receive respite through the EDF Foundation, I used those hours to volunteer at my youngest daughter's school. I'm not asking to go on elaborate things. We're asking for everyday Monday tasks that most people can do, like going to a grocery shopping, without much thought.
Thank you. Mr. Pruden, or Captain Pruden, Wounded Warriors Project does a great job of advocating the needs for veterans and PTSD and TBI. In your view, what's the biggest gaps in the VA current support programs for caregivers when they assist a veteran?
Obviously, you have to have the supports in place for the veteran. And part of the Elizabeth Dole Act, Section 105, covers access standards for rehabilitation care, residential rehabilitative care, because, as you know, those with PTS, TBI, and often comorbid substance abuse issues, when they need to go into care, usually it's precipitated by a crisis that impacts their family, their children directly. They say, I'm ready to go. Get me help. Having to wait weeks and months for care is not appropriate and not okay. And too often, that impact, if it's allowed to go on, has a hugely damaging effect on our caregivers and their families. And as Vanessa pointed out, and Dr. Richardson pointed out, the VA is a giant complex web of programs and services. And so we need better case coordination for our caregivers so that they can help navigate the system into the good programs that do exist inside VA.
Thank you. With that, I yield back, and I'm Representative Brownlee. Recognize 5 minutes.
Thank you, Mr. Chair, and thank you, Mr. Ranking Member, for allowing me to go. I'm late for a meeting, so I appreciate it very much. Ms. Chism, I just wanted to also chime in here to thank you for being here today and your testimony. Everyone on the panel gave excellent testimony today, but yours really penetrates in our psyche, and it's really, really important to hear stories like yours. It means a great deal, and it's most impactful to hear your story and to hear your experiences. And I just want to thank you for that and really do honor your perseverance and as you said, this is my choice, and I will continue to make it. It's just, to me, it gives me chills, and I'm very impressed and very, very grateful to your service to our country as well. So thank you for that. Dr. Ramchand, I wanted to ask you about some elements in the report, and I think the report highlights that caregivers for veterans who are under the age of 60 are at higher risk of depression and are less likely to seek care than non-caregivers. So this is really an important point for me. I mean, it is, and I'm not sure how we solve the problem. I think awareness that their help is out there, I think, is very important. But I also think that perhaps we need to require some way, shape, or form, whether it's by video or something, that if someone's going to step up to do a caregiving job, that they need to listen to this video from the VA that talks about the statistics that you've uncovered here for folks that are under 60. And most importantly, I think to make them feel that they're not alone in all of this, that there's a whole sea of caregivers like you going through similar things, and to seek help. I mean, it's taken us a long time to convince veterans to seek help. And I think we need to sort of do the same thing for caregivers. And if they're going to do caregiving under the envelope of the VA, I think the VA should be doing something to make sure that they are aware of the programs and not feel alone. Does that make sense to you, or?
It does make sense. I think that in addition, and thank you for the statement and the comment, I think that we really explored alternative delivery models for vet care. I think that the current models that exist, and you mentioned earlier, telehealth is increasing, and I think that that holds a lot of promise and should be made more available. But I think other methods like integrating mental health care into primary care, asynchronous counseling we bring up in our report, which is kind of text message-based counseling to help with stress, all these alternative methods that kind of address this barrier of time. People, Vanessa's story, she's doing things all the time. To even take 3 hours out to go to a mental health appointment once a week or once 2 weeks, it might not be attainable. So how do we meet people where they're at? Our report describes some of those options, but I think that that's really kind of the critical. Even forcing them could create more stress. We have to let them kind of direct it. So that's what I think are some really unique opportunities there.
Okay, very good. I mean, I don't mean to use the word force, but just a requirement that when you join the program, you have to listen to this 30-minute video so that people understand what the services are and not feel alone. But I get your point. I really, really do. And I also, you might not know this, but when you talk about 20% of caregivers in this group have had thoughts in the past year about suicide, taking their own lives, I'm just wondering if the VA is, if those veterans who we know have committed suicide, do they know this element of the fact that they potentially could be caregivers? And I don't know whether, I'll follow up with the VA to find that out, but that would be an important data point. And you also mentioned about the interstate licensure, but within the VA we do have this telehealth, and we can go. We have the supremacy law, and we can go across state lines. So it's not so much of an issue within the VA. Outside of the VA, it's a whole nother community care. It's another challenge.
Right, and so for caregivers, the only ones that are getting mental health care from the VA are those enrolled in that PCAFC program.
Yeah.
So the majority of that, 13.7, however many it is, million military and veteran caregivers, that's not really an option. So they're receiving care in the community.
Yeah, very, very good. And you mentioned a tax credit, which I think is a really good idea. I think it should be a tax credit that we did in the rescue plan, which gives folks the money up front and not having to wait or be required to do their taxes. Many people don't make enough income to even do their taxes, but we can talk about that later. But Mr. Broussard, you mentioned that Oklahoma and Kentucky both have tax credits. What do their tax credits look like?
Yeah, it's actually Oklahoma and Nebraska.
Oh, Oklahoma and
okay.
Nebraska.
And what
That's exactly what I wrote down, but I didn't say that.
I think after you made it through Broussard pronouncing that, so you're good in my
Okay,
book,
good.
for sure.
Good,
Okay.
good.
And it's a $2,000 tax credit that's for most caregivers, but it's a higher maximum of $3,000 for family caregivers of a veteran, and those were passed by those states, and I think that's a great model to look at and to start with. So $2,000 for regular caregivers, and if it's with veterans, it'll be up to $3,000.
Great.
Thank you so
Thank
much.
you. And Dr. Ramchand, one last question. You stated that your study says that caregivers generally forego around $4,500 in earnings each year. That seems low to me, but that's That's what the conclusion is?
Yeah, it's an average, and we really base it upon, well, we look at income and we look at comparing to non-caregivers and caregivers' income. What we found is that that's mostly driven by work disruptions, as you could imagine. Around 27% of caregivers in our study reported a work disruption, 11% switched jobs, so we have that broken out into the types of disruptions that they've experienced. But certainly, many caregivers are leaving the labor force completely, and we have those numbers as well. But there's a lot that are juggling both caregiving and work. And so we present an average, but certainly, a lot of caregivers, and we've heard anecdotally, as well as we have a qualitative component of the report that describe many of whom have had to give up, participation in the labor force.
Very good. Thank you, Mr. Chairman. I yield back.
Ranking member, you're recognized.
Thank you, Mr. Chairman. I want to just commend Congresswoman Brownlee for her tremendous expertise and work she's done in this policy area. Ms. Chism, you testified, I want to just make sure that I'm getting it right. You started caregiving at a young age, is that right? And you're doing this full time?
Yes, I was 26.
You started when you were 26, you said, and I'm assuming your husband is 100% service-connected, disabled, and he gets 100%, and he gets a disability pension.
Yes.
And the stipend you get is you're enrolled in the family caregiver program, so you get a stipend, and that's helpful, the combined income. And I don't want to delve into all the other ways in which your family may be supported, but I'm troubled by the fact that people your age, caregivers your age, you're not only out of the workforce, but the stipend you're getting, it is what it is. But you're not earning any Social Security credit for that, right?
No, I earn there's no credit for that whatsoever. And I have actually recently, I am employed, but I had to find a job that was actually work for a nonprofit VSO, that they are incredibly flexible. I work remotely because I am concerned that we will be just completely eliminated, which would cause financial ruin for my family. I mean, even though I would like to point out that stipend, I am tier 3 in the DMV area, and I get paid about $110 a day.
Okay.
For 24-hour care, yeah. So
well,
that's something that, yeah.
You are certainly saving the American taxpayer money by being a full-time caregiver. You're having to go out and find a job that allows you to do this work. I think I want to work with the chairman to fix this particular issue that you're not earning Social Security credit, and you could be out of. It's a real strain. A number of years you're going to be doing this. I'm also concerned about you have 3 young kids, and I think it could be a challenge that you're taking care of kids and husband, and sometimes families are also taking care of elders. And I'm hearing that the kids are likely to have emotional and conduct problems in these households. I'm not saying that yours are having those problems, but that it's a challenge for everybody involved. And are the children eligible for CHAMP VA as well, and able to get mental health services they might need?
Because my husband was medically retired, we have access to TRICARE. So we have TRICARE. Though the veterans who were not medically retired, they do not have that.
So there's a gap there.
There's a gap there, yes.
So we need to, because I'm thinking in such cases where we have caregiver needs, we need to think about not just the caregiver, but the kids in the household too, right? Making sure that they're supported. I am, Dr. Ramchand, how do you propose that VA expand its definition of caregiver to include those caring for veterans with a substance abuse disorder or a mental health condition?
Well, it's a great question. There's not much precedent for it. We really scratched the surface by looking at people who are helping with memory tasks as well as people who are helping manage mood and anxiety. We believe that there needs to be more work to really start quantifying the aspects of caregiving to individuals with these conditions so we could delineate more what those tasks involve, which are most beneficial, so that we can come up with some kind of proxy similar to how we use ADLs and IADLs, but something that's more cognizant of those mental health conditions. But right now, we don't have kind of the empirical data to do that. In the meantime, I think that we can take examples that account for narratives provided by caregivers that account for these things. And I realize that that might be laborious, but we do have kind of technologies right now that could be really helpful in starting to quantify what these caregivers are doing and take conditions like this into consideration so that we can really start thinking more inclusively about caregivers to those with these challenges.
Well, I just want to ask you another follow-up if I can. Do you think VA has a role to play in ensuring caregivers are connected with additional support services like SNAP, WIC, and SSI? What are some of the ways that VA can connect veterans and caregivers with other federal benefits? And it's kind of like an add-on to what I was talking about with making sure that the caregiver, even the family program, is getting like Social Security credits at least.
I mean, I'm a big proponent, and I think the research supports these no wrong door policies. So when a caregiver goes in to seek support for the first time, the person that they're talking to, whether that's at the VA or at a VSO, be aware of these benefits, or at least be thinking about these benefits so that they can help the caregiver figure it out. As we've heard, caregivers are very burdened, they're very tired. Having them kind of cruise around, Googling what benefits that might be available to them is probably not the most efficient way. And so those who are kind of, raise their hand to help support caregivers, ensuring that they have that knowledge and can help them apply for those programs, I think would be a tremendous asset.
Well, thank you. I've gone over my time. I'm going to yield back, Mr. Chairman.
Mr. McGarvey.
Thank you very much, Mr. Chairman. Ms. Chism, I just want to echo everyone else's comments. Your testimony is incredible. It's impactful. It's courageous. We're so appreciative of you and your service, and want to make sure we recognize that. I'd also like to thank Rand, the Elizabeth Dole Foundation, everyone on this panel. Thank you. Thank you for the incredible work you all have done to develop and share the insights of this year's Caregiver Report. I mean, truly phenomenal job, and I hope a lot of people are paying attention to what you all are saying today. You've identified how caregivers, more than ever before, are invested and how much time and effort in getting a deeper understanding of their unique experiences, their strengths, their challenges, their character. I also want to extend a personal warm welcome to Mr. Troy Broussard, the State Director of the AARP from my hometown of Louisville, Kentucky. And a proud Army veteran to boot. So thank you, Mr. Broussard, for all of your service. Appreciate what you do for the caregivers throughout our district and the great Commonwealth, Kentucky. It's always great to have another Louisvillian up here. Right. So we'll get into some questions now that we've thanked everybody. I'd like to explore whether there are promising home care support programs and models that you all have seen implemented, or ideas you have on how the VA can implement and test programs that are more responsive to the caregiver's unique needs and preferences. While there are over 14 million military and veteran caregivers, RAND studies suggest that 40% of adults in this country provide some form of caregiving. While the VA has more work to do to improve its caregiver support programs, they're actually leading the way in terms of large-scale support infrastructure for caregivers. The VA is uniquely positioned, given its size, to inform broader models of support that impact the lives of millions of Americans, providing care to non-military veteran loved ones. Mr. Broussard, you mentioned different models in your testimony and ideas such as tax credits. Do you think the VA is a good testing ground for these sorts of innovative ideas to assist our caregivers?
Thank you, Congressman McGarvey, for that question. The VA, we feel, is a good place to test those innovative ideas to support those caregivers. Both VA and non-VA caregiver support efforts can learn from and build on each other. You know, the self-direction programs that allow family caregivers to be paid for providing care for their loved one is extremely important. That model is in the VA under veteran-directed care, which is being expanded in the VA, which is great. And like I mentioned earlier, Oklahoma and Nebraska have enacted those tax credits, so that could be something we feel that'd be very important. And then lastly, the VA program of comprehensive assistance for family caregivers provides family caregivers training to assist in delivering this personal care services to a veteran. So I think that would be important, and Medicare now reimburses that. So I think that could be a good testing ground with the VA to attempt to do that. We'll be more than happy to help support that as well.
I appreciate that, and that's support we want to see.
Yep.
In fact, something I've said before, I'll continue to say, and you'll see more from me in the coming months and years, is I think the VA should have a fifth mission of innovation because of its ability with its broad scale to implement some of these ideas that, of course, are not just fantastic for our veterans, the men and women who are willing to put on a uniform and sacrifice everything for us, but they can also be applied outside of the veteran context and be beneficial to everybody. So, Dr. Ramchand, go to you next and ask, where do you see opportunities for innovation and impact in the realm of home support service programs at the VA? And how can the VA better develop pilot programs or better scale what they're already piloting to help our caregivers?
I think that really the opportunities abound. I think, as I've been kind of stating, the big need is support for mental health care and substance use. So what does home-based care look like? What are those needs? I think that there's real opportunities for pilot. The VA has a strong research arm within it, and so I think there's a lot of kind of research potential. Should the researchers be encouraged to start looking at veteran caregivers, especially those with mental health or cognitive conditions, as well as complex needs. So I do think that those are ways in which the VA could really be that proving testing ground for some of these novel approaches.
Okay. And anything on the pilot programs or better scaling? Sure, go ahead. I mean, I was part of the question to you, but Mr. Schwab, you seem to want to jump in.
I would just like to
mention...
mention...
You got 4 seconds.
I'd just like to... respite has come up quite a bit today. Vanessa talked about her challenges around utilization of respite and the delivery of respite. VDC, that program, we need to see a fast expansion across VA to open up those channels. But I'd also like to acknowledge that she mentioned a program that we delivered through the Dole Foundation that was flexible, timely, and responsive to veteran respite, caregiver respite needs when they need them. I'm a big believer in what you said around innovation, and VHA is looking at that respite model and seeing how it might be able to be piloted and expanded across VA, and we'd really like to see that happen.
Thank you all so much. I really appreciate your testimony and appreciate your service. Thank you.
This time, if the ranking member has any closing remarks.
Mr. Chairman, I think this has been a very bipartisan, productive committee hearing, and I want to commend you for bringing us all together. I want to express my gratitude to all the witnesses who have appeared before us today, and I want to thank all my members for being here, especially as we're ending the October recess. You all should know that it's an impressive number of members that showed up, and it's because your cause, I think, is so sympathetic. And again, Ms. Chism and all the caregivers who are here in the room today, the nation owes you a great debt of gratitude. But we owe you more than gratitude. We owe you real support. And I'll be working really hard with the chairman to make that happen. So thank you so much.
I want to thank the ranking member. I agree with his remarks. I'm going to associate myself with that and each one of the witnesses. Ms. Chisholm, I did express, and it is not, it's not easy to come before Congress, but I guarantee you the ranking member was right, and the amount of members that made sure they were here to discuss this. And I want to thank all of the witnesses, but I also want to thank all the caregivers that are out there in the audience today. Thank you for being here. We couldn't do our work without the advocacy that you do to inform us of the problems that we face, not only in the caregiver realm, but also as we try to make sure that the VA is doing what the VA is supposed to do. Many of the issues that were raised today are addressed in the passage of H.R. 8371. That's a Dole Act. We appreciate your support. So with that, I ask unanimous consent that all members shall have 5 legislative days in which to revise and extend their remarks and include extenuous material. Hearing no objection, so ordered. The hearing is adjourned.